बच जाएगा जी सर। He's able to join. Yes. हेलो सर, आपने ज्वाइन तो कर लिया है? हाँ, ज्वाइन आपने कर लिया है। Here, stalwarts here will be sharing their topics, their mindsets to us, and we are going to have this in series form. So this is the first thing in which we are just trying to emphasize more on the basics, and in the next one we are going to go further. So welcome all, and I think President-elect and Secretary General Dr. Atul Srivastava, President, are going to join. But meanwhile, I think Dr. Anup is here. Anyway.
Yes, I am there, sir.
Oh, okay, fine. So meanwhile, we'll request our President, Indian Stem Cell Study Group Association, Professor Agrawal from AIMS, Raipur, to give the presidential address. Over to Professor Alok. Welcome, sir.
Good afternoon, friends. On behalf of the Indian Orthobiologics Association and Indian Stem Cell Study Group Association, I am very much privileged to have this session on orthobiologics and especially for avascular necrosis, because it is an important topic. Following COVID, the things have improved, but more and more cases of avascular necrosis are coming, and then it is difficult to manage them. It is good that Indian Orthopedic Association has recognized that Indian Orthopedic Society and Indian Orthopedic Stem Cell Society and come out with this. I thank Dr. Atul Srivastava, the President, Dr. Chadda, Dr. Anup Agrawal, and Dr. Naveen Thakkar, who will be joining us shortly. And I am thankful to Dr. Professor Manish Khanna. This association, his brainchild, is now doing good, and will be coming with this all series on AVN. Thank you.
Thank you so much, sir, for the kind words. Now, I think Dr. Chadda is here with us. Dr. Chadda, sir, are you here? Great.
Yeah,
great.
very much. I am with you, Manish ji. Namaskar. Good evening.
Namaskar. Namaskar. Thank you so much, sir, for joining. So now our own very favorite Dr. Chadda, the IOA President-elect, is here. So we'll like, sir, for you to have few words before we start the first session for the AVN. We are going to have a series out of it, but this is the first one right now. Over to Dr. Chadda, sir.
Good evening, everybody. On behalf of the Indian Orthopedic Association, our President, Dr. Atul Srivastava, and the entire team, I welcome all of you. It's indeed an excellent initiative on behalf of the spine, on behalf of the stem cell group. I keep saying spine, I apologize, the stem cell group. And I am happy that we are evolving and moving towards those paths which were unexplored. And both Dr. Manish Khanna and Dr. Alok Agrawal need a huge pat on their back for having gotten together so contemporary, something so important today, which is avascular necrosis of the hip. And I really appreciate you have a good program, and I wish you luck. And I believe that this is going to add value to what we are seeing so often nowadays, which is avascular necrosis of the hip, more so post-COVID. So all the best. Happy educating each other, learning from each other. It's a pleasure to be here.
Thank you so much. Thank you so much for
Thank
such
you
a
for inviting us.
Yeah, thank you so much. Thank you so much for the kind words. Thank you so much. So now the science fair program is ready to unfold before you. So here we go. The first session is early diagnosis is important, and we feel it very important because a lot of us see the patients at a later stage when the arthroplasty is the answer. So early diagnosis is again a gray area. how to do early diagnosis, what are the things which needed to be picked up. So that we are going to discuss in this session. We are very lucky to have Professor Tanmoy Mohanty sir and Professor Dr. Anup Kumar from Dr. Tanmoy Mohanty from Bhubaneswar, Dr. Anup Kumar sir from Patna AIMS to chair this session. Over to our chairs, Professor Mohanty sir and Dr. Anup Kumar. Dr. Mohanty sir. Sir, you're muted. Thank you so much, sir.
Very much. Without wasting any time, I see Anup is with me, and we have got excellent speakers. And all these speakers will be talking within 7 minutes, 5 to 7 minutes. They will give their message. My request is to stick to time because it has been fixed accordingly. Then we can have a panel discussion on 15 minutes.
Yeah.
We have first speaker, Dr. Aarti Devan, and she will be talking about the etiological update.
So, sir, I'll request, take your permission to share my screen first of all, so as to just give a basic emphasis before Dr. Aarti Devan. Just a second.
Okay.
Yeah. Because I have something more in the mind for today's webinar. Yeah. And I'm sorry that I was not able to do it first. So here we go with the permission of the chairs. Lord Ganesh symbol is exhalated intelligence, and just we have finished the Ganesh Vandana. So let's see if we can go for it before having it.
We can't listen.
वक्रतुंडाय गौरीतनयाय धीमहि प्रजेशानाय भालचंद्राय श्रीगणेशाय धीमहि
Thank you so much. Is my screen visible, sir? So evolution of flexibility and stability. As orthopedics has been moved from the wards of conservative management to the operative management, surgical management, with emphasis to the rehabilitation as well as the recent advances, maybe it's a surgical advances, or maybe arthroplasty, or maybe even a stem cell. So the stability has been increased, but definitely we need to stabilize our mind also to go for it. AVN is such a disease which have number of causes and a list of idiopathic reasons also. Why I'm saying a list of idiopathic reasons, because nowadays I think we all agree that there is no idiopathic cause. Everything has a cause to it, and that we're going to unfold in this first lecture by Dr. Aarti Devan. Entire list would be there, but the most important for me and all of us orthopedic surgeons which are seeing is the young males, the young male fraternity doing a lot of pumping of the irons, having an obsession with a anabolic steroid. That was the era before the COVID, and then the COVID came. And then even if the patient has taken the steroid, even the patient has not taken the steroid, they were having it, and we know what's the reason about it. So over to Dr. Aarti Devan, Associate Professor from SGRM Amritsar, the etiological update. Now I'll stop sharing my screen and I'll request Dr. Narvesh sir to just do the needful.
Thank you, Dr. Manish. Thank you, Dr.
Yeah, we can see. Yeah, over. Dr. Aarti.
Thank you so much. Good afternoon, everybody. That's a very important topic, avian, about the etiology. As we all know, we are all aware of it, that bones and the musculoskeletal system, the main function is protection, movement, and rigidity to our body. Everybody knows bone and the bone marrow of the human body, it needs steady blood supply. That should give us the health to the bones. The blood supply is very important, so collagen in the bone replenishes and gives us a new skeletal system. If the blood flow to the bone, as we all know, decreases or diminishes, it leads resulting to the trigger onset of bone necrosis, that we are talking about avascular necrosis. Next slide, please. Dr. Narvesh, next slide, please.
Dr. Navesh, please. Yeah, thank you.
So I should carry on that among the pathologies of the hip, ABN, that is the most challenging and the intriguing situation. Multifactorial disease, it has high variable spectrum of its clinical presentation and prognosis, which makes it difficult to determine a specific treatment. There are devastating effects due to disabling painful conditions, both for the usual activities and the sports. As we all know that AVN in young patients, it's more. And as Dr. Manish has told, in six packs, now in the youngsters, it's very common. The pain is insidious. So AVN, that's the most common cause of the hip. So what is the etiology behind it? Evolution is very difficult. Treatment, of course, it's hip salvage or replacement, depends on which stage it is. So other bones as all involved, humerus, scaphoid, and avian is this. Next slide, please. In etiology, Dr. Narvesh, next slide, please. I'm audible, Dr. Narvesh?
Yeah. Please.
So etiology, there are traumatic as well as atraumatic causes. Mostly it's idiopathic, as we know. In trauma, displaced fractures, dislocations, subluxation, iatrogenic secondary to nailing, these are the causes. And in atraumatic, it's almost idiopathic, but it's not idiopathic. When pain is there, we are not able to diagnose it. So it comes that we go for X-ray pelvis in young patients. Then steroids, of course, alcohol, that's very common, smoking, globulopathies, myeloproliferative disorders, then decompression, hyperlipidemia, infection, all we are aware of it. So coming up to the trauma. Next slide, please. Cutting short, that femoral neck fractures, these are the commonest. Swellings of the blood supply to the femoral head, it gets disturbed, that leads to avascular necrosis. That's the common part. And the references they are given, so that trauma is the most important cause for avascular necrosis. Next slide, please. Traumatic osteonecrosis, there are fracture dislocations of the hip, tear of the reticular vessels. This is all the pathophysiology, but the main is that trauma that leads to osteonecrosis. And the references there of the Charles that shows that there is traumatic osteonecrosis. Next slide, please. Next slide. The closed compartments, you're aware of that vascular sinusoids are there. There are no adventitial layers, that leads to decrease in the patency, volume, and pressure of the marrow tissues. Marrow that is encased in the bone, that leads to compression, that leads to avascular necrosis. Next slide. Next slide, please. The non-traumatic causes. Ischemia, that is multifactorial. Swellings of the local blood supply, venous stasis is there, and retrograde arterial stoppage, that leads to compression of the capillaries and sinusoids, that lead to avascular necrosis. So what are the main causes behind the non-traumatic? Smoking, that's very common. Alcohol, that's very common in our privilege, in our setup. Steroid, after the COVID, that has come up, that's the most important reason that has come up in the latest etiology regarding that how much steroid can lead to avascular necrosis, how much dosage of steroid can lead to avascular necrosis. Next slide. Steroid induced. So corticosteroids, prednisolone, methylprednisolone, used in the treatment of asthma, skin diseases, immunological disorders, steroid-induced. It's always avascular necrosis is in the literature. It is reported that it's bilateral. So 20 mg, more than 20 mg is, standard that leads to avascular necrosis that has been reported. Next slide, please. Alcohol abuse. So how much alcohol, that all we know, that's the commonest disorder, commonest etiology behind the avascular necrosis. So both have the link, alcohol and steroid. They contribute greater than 65% of the non-traumatic causes of the avascular necrosis. The average duration of the alcohol abuse when AVN develops is around 10 years with a range of 8 to 20 years. So how much alcohol per week? It's like 400 ml, or now it has increased to 1000 ml. So some people say that it should be greater than 400 ml. It leads to avascular necrosis, but the latest studies, they show that 100 ml per week, they can 100 ml per week, they can be the cause for alcohol and AVN. Then next slide, please. Smoking, then the etiological factor that has come up. So it contains nicotine, which causes osteonecrosis by the possible two mechanisms. So it causes narrowing, as we know, and the blood supply. So all the things, they come to the blood supply, of course, that is necrose, the bone that replenishes, there is decrease in the blood flow, blood cells, they get die, the osteocytes, osteoblasts, and the osteocytes. So all these, they trigger the onset of bone necrosis that leads to avascular necrosis. Then other etiological factors, next please. The hemoglobinopathies, they are the frequent and the severe complications in the sickle cell anemia, as we all are aware of, because the blood supply is decreased. Then the myoproliferative disorders like polycythemia vera, essential, thrombocytopenia, myelofibrosis, chronic myeloid leukemia, that is characterized by the partial or the total accretion of the microcirculation. Next slide. The hyperlipidemias, we are all aware, these are the common causes, because hyperlipidemia, that is associated with increased serum lipoprotein. So these are the blood tests we have to go for, but that shows on the shows effect on the bone, and there we can see that there is a there is decrease in the blood supply that leads to avascular necrosis, or the patient come up with the if we are aware of in the history, the patient comes that it is a main cause of, it can also be the cause of AVN. Then the latest cause is the infection. Next slide, please. After the COVID, there are coagulopathies in the patient, especially the hypercoagulability that leads to venous thrombosis and avascular necrosis. So corticosteroids given in the infection, this is one of the most common cause that has come up after the COVID. That is the main reason. So how much steroid can induce avascular necrosis, how much should be taken? And in acute respiratory disorders, corticosteroids, they have been given, and this has come up as an etiological factor. Thank you so much. Thank you so much. These are the etiological updates.
Thank you so much, Dr. Aarti, for a wonderful presentation. Please stop sharing, Dr. Navesh, if possible. Yeah, thank you so much. So definitely, yes, the preserving has to be worked up from the day one. And definitely as an orthopedic surgeon, if apart from the trauma, apart from the reason when really the blood supply has been broken, the rest of the causes are sometime a nightmare. Ultimately, the most important thing is the increase in the intraluminal pressure. With the venous congestion, as been very well explained, it may be a COVID, maybe a steroid induced, maybe alcohol induced. So whatever the reasons may be, the reasons are very important. And I think Dr. Our Secretary General has already joined. Is he here? Fine. So moving to the next presentation, yes, as an orthopedic surgeon, we are not bothered much about the histopathology, but believe me, with the recent advances, it has been very well explained that the MSC count, it is a different part of a histopathological part. MSC count is low in avian head, and we are doing a lot of studies also on that. Now, in orthobiologics, we are interested in MSCs or progenitor cells, but truly speaking, the histopathological changes are very important, because they can give a upper hand while managing these cases to a particular extent. So I'll again check whether our Secretary General has joined or not. Fine. So now I'll request Professor Kiran Sauji, sir, who is a Professor Emeritus from JNMC Wardha, who has taken out his special time today for this role of histopathology. This presentation needs to be, worked up and to be attended very carefully because it's going to give answers to many questions. Over to Professor Kiran sir. I'll stop sharing my screen and I'll request Professor Kiran sir to share his screen.
Thank you, sir. Am I audible?
Yeah, you're audible,
Yes,
sir.
sir.
Please go for the slideshow mode, sir.
Good evening, everyone. Today I am going to speak on role of histopathological examination in non-traumatic avascular necrosis of the femoral head. This is very important because nobody does the histopathology in avian. Avascular necrosis of hip is a huge problem in central India. The reasons are many, as Dr. Just now told. High prevalence of sickle cell disease in our area, alcohol-induced, steroid-induced, and supplements for bodybuilding. In our experience, we have encountered a changing trend of young patients, those who are more affected. This leads to the strong need to preserve the femoral head and defer the decision of arthroplasty. Currently, the diagnosis of avian is based on clinical acumen complemented by radiological evidence gathered from X-ray and MRI. Histopathological examination is casual. See, all orthopedic surgeons, they don't give more importance to histopathology while treating avian. They just see the X-ray or MRI. There are no defined guidelines about the role of histopathological examination in avian of femoral head. In avian of femoral head, histological evidence with specific etiopathogenesis is lacking. Even in literature, it is imperative that while diagnosing the cases of avascular necrosis clinically, a histopathological examination should also be conducted to confirm that the correct diagnosis is made. While doing the management, the surgical management, the dilemma regarding the head preservation or replacement, particularly in different stages. Current practice of our orthopedic surgeon is to see the radiological X-ray and MRI and then classify them in grade 1, grade 2, grade 3 and grade 4. Grade 1 and 2 goes for the head preservation with core decompression and all other conservative treatment, and grade 3 and 4 goes for a total hip arthroplasty. The role of histopathological examination along with clinical and radiological correlation is primitively investigated in our study. Aim of the study to evidence-based medicine practice, propagating head preservation, avoiding permanent morbidities, particularly in young patients who are going for a THA. We conducted this study to establish the importance of histopathological diagnosis in non-traumatic avascular necrosis of femoral head with its etiological factors, to analyze and correlate it with clinical and radiological diagnosis and make a protocol for management. Problem is, there is an uncertain role of histopathological examination in non-traumatic avian of femoral head. Intervention, what we have done, that is intervention, histopathological examination of the tissue sample obtained by core biopsy of the femoral head, evaluating with predefined parameters. 10 patients of each group we have taken, depending on etiological factor, that is A is alcohol, B is sickle cell disease, C is corticosteroid, and I is idiopathy. Outcome, categorize and type of histopathological examination features of avian, classify them into different groups based on correlation between the clinical grade, radiological stage, and histopathological stage. Femoral head biopsies were studied for macroscopical and microscopic features by senior pathologists. Typing was carried out on each sample based on 12 histopathological features. See, these are the 12 structure Histopathological features: plasma stasis, architecture of trabecular theme, foam cells, focal area of granular eosinophilic necrosis, marrow necrosis, granular necrotic infiltrate in medullary space, eosinophilic necrosis, unexplained non-traumatic hemorrhages, fibrosis, hematopoietic marrow necrosis, trabecular necrosis, and fibrosis. These are 12 points. Now coming to the type 1, we have done classified into 4 types of histopathology. Type 1 shows 4 points: plasma stasis, architectural trabecular theme, foam cells, and focal area of granular eosinophilic necrosis. Type 2, all features of type 1 and marrow necrosis, granular necrotic infiltrate in medullary space, eosinophilic necrosis, unexplained non-traumatic hemorrhages, fibrosis, and hemophilic necrosis, marrow necrosis. These are 7 plus points. Then type 3, features present in type 1 and 2 plus trabecular necrosis with 50% of death of osteocyte, and type 4, features present in type 1, 2, and 3 plus complete loss of trabecular architecture with necrosis, presence of fibrosis, and creeping of fibrotic substitution. Now, based on our observation from study, we came up with the new severity score system based on clinical, histopathological, and radiological features in patients with AVR. Table, this is known as CAS severity score system based on clinical histopathological correlation. Now, we have given 10 points to each. That means range of movement, grade 1, 2, 3, 4, VAS score per pain. From if there is a VAS score 1 to 3, 10 points, 4 to 6, 20 points, 7 to 9, depending on the pain of the patient. Then histopathological, similarly, type 1, 2, 3, and 4, each given we have 10 point, 20, 30, and 40. Then radiological stages, stage 1, 2, and 3, and 4, again 10, 20, 30, 40 points. Now, 10 to 30, we have then based on CAS severity score management protocol, that is 10 to 30, conservative management with different modalities like bisphosphonate and other drugs. Then 30 to 80, core decompression with or without adjunct therapy, and 80 to 60, total 80 to 160 points, total hip arthroplasty. Now, clinical and radiological and histopathological correlation. This is group A. A means alcohol induced. What findings we have got? There is a younger generation was involved. Clinically painful plus mild range of movement restriction. Early radiological stage 1 and 2 with early histopathological type 1 and 2. Then treatment will be CAS score was 30 to 80, and treatment will be explored for head preservation with minimum intervention. Group B means sickle cell disease. Middle age, mostly middle age, clinical pain and severe restriction of movement. Late radiological stage 3 and 4, moderate histopathological type 2 and 3. CAS score 30 to 100. Then group C, that is corticosteroid induced. Young to middle age group, clinical pain plus moderate restriction of movement. Late radiological stage 3 and 4, moderate histopathological 2 and 3. CAS score was 30 to 140. Again, explore for head preservation or added treatment. And grade group I means idiopathy. Middle to elderly age group, clinically pain and severe restriction of movement. Late radiological stages 3 and 4, moderate histopathology 2 and 3, and highest chance of misdiagnosis. CAS score was 90 to 160. The observation, the range of motion is independent of type of histopathological examination. Head preservation decision cannot rely only on mechanical restriction. Clinical signs do not indicate the severity of the disease. Mechanically appear more severe than biologically, not significant. Management plan should be inclusive of histopathological examination typing, as it is not contradictory. It is complementary. Independent of radiological staging, histological typing alone with clinical grading is necessary to explore the possibility of head preservation. Our aim is to, out of 10, which are going for the total hip replacement, even if we can say 1 or 2 heads by doing histopathology, then we will serve the purpose. Conclusion, there is a disparity between histopathological typing and radiological staging. There are patients who are radiologically stage 3 or 4, but histopathologically stage 2 or 3. such patients we can definitely preserve the hip by not doing THA. Evidence generated towards the definitive role of histopathological examination. Evidence generated for better decision making towards the head preservation surgery in avascular necrosis of the femoral head. See, this is our conclusion. Moderate to strong systemic review literature shows moderate to strong evidence indicated that radiological investigation and histopathology have a significantly associated with better diagnosis of avascular necrosis and avascular necrosis of femoral. See, this is our paper. The conclusion: there is no relationship between the radiological stage and histology due to the overlapping and extension of necrotic lesion. Then another paper: histopathological aspect and staging system in non-traumatic femoral head osteonecrosis overview. Exploring the etiological evidences and avascular necrosis of femoral head by investigative approaches of histopathological clinical assessment and radiology. This is our publication. This is another publication. Then take-home message: before classifying the patients at a certain stage, after having clinical and imaging data, histopathological aspects should be considered. Particularly in patients in stages 3 and 4, the severity score should be calculated according to our score. In the future, validated severity score of osteonecrosis of femoral head analysis are required for a comprehensive picture of tissue quality and to decide the plan of management. Thank you very much.
Thank you so much for sir excellent enlightening presentation, specifically on the histopathological aspect, because we always go for the radiological point of view for deciding the treatment modality, especially the necrosis, the type of necrosis, the CAS severity score. Thank you so much, sir. Sir, please stop sharing your screen.
Yeah.
And now we request our own IOA Secretary General, Dr. Naveen Thakkar. I'm so sorry, Naveen Thakkar, sir. Are you here, sir?
Yes, I am here.
Sir, welcome, sir.
Thank you.
Yeah, please
Good
have a.
afternoon to everybody. Can you?
Yeah, we can hear you, sir. Please go ahead, sir.
Okay. At IOA,
sir,
we are thankful to all the faculty. Professor Tanmoy Mohanty ji, Dr. Professor Magoo sir, Dr. Alok Agrawal, Dr. Kiran Sahu ji has given a very good lecture here. Dr. Aarti has given, Dr. Sandeep, Srivastava, and Dr. Karne, and everybody, those who are delegates also. We are thankful to you for such a fantastic academic program, and this committee is very vibrant. Rheumatology and this biologics is a very vibrant committee and working very hard to spread the knowledge. So we are thankful to you. So please go ahead with the academic program. We will not like to disturb much.
Thank you so much, sir. Thank you so much, sir, for the nice words. Thank you so much.
Dr. D.P. Bhusan, sir.
Dr. Bhushan, sir, welcome,
Good afternoon,
sir. So now our convener is also here, Professor Dr. D.P. Bhushan from Dhanbad. Over to sir.
Thakkar, sir.
Yes, sir.
We do not have enough material to do webinars every month, but we are very substantial and we talk very much sense and very much reality. So,
yes.
not considering the number, but the quality, we
Yes.
should be considered for the final tally.
Yes, it will be considered. You are getting award every IOCON. Committee is getting
Does not make a difference, sir. Does not make a
पिछली बार तो rheumatology में आया सर, इस बार
because of your hard work and perseverance.
नहीं, it
This
is
is
the
our third in
judicious
number.
एक second. It is judicious value pinning of Dr. Naveen Thakkar and the president. We are thankful to both of you. Chalo, bhai, Manish, please continue.
Yeah. Thank you so much. Thank you so much, sir. So now, sir, stop sharing your screen, sir. Yeah. So now over to for moving ahead for the next presentation. So yes, the suspicion is the most important thing. Finally, in the clinical presentation, that yes, okay, fine, histopathological examination, radiological examination, but now the most important thing is the classificational practical implications. So clinical pictures may be non-specific. Sometime early radiological changes not been seen if the MRI is not been done. So the most important thing challenging is going for a classification. Level of classifications are there, especially from FICAT and ARLET, then Shimuzu classification, then now Steenberg proposed extension form of the FICAT and ARLET. But definitely ARCO staging has to be remembered. And now the classification, these practical implication, how to pick it up. So we are very lucky. Dr. N.J. Karne sir is here from Pune. He's the chair office from Orthopedic Committee, IOA, Office Orthopedic Committee. Over to Karne sir for this very interesting, enlightening topic, which will clear a lot of doubts for us for the classification, practical implication. If it is there, then how? Please, Dr. Karne.
Yeah. Thank you very much. Can I share a screen now? Okay.
Please, sir. Please, sir.
Well, first of all, I thank Indian Stem Cell Group and IOA for arranging such a wonderful webinar, and especially Professor Dr. Manish Khanna, who is a extremely talented and hardworking and enthusiastic one, and he has a tremendous perseverance to go ahead with all these important topics. So I thank all the faculty as well as the office bearers. Well, now we will go for the avian classification and its practical implication. I don't go in much didactic things. Well, we'll go directly to the background. There are many studies have confirmed that the size and location of the necrotic lesion are major factors that affect the prevalence or the incidence of the collapse as well as the prognosis. Although several classification streams to categorize as well as quantify osteonecrosis has been there, yet there is no consensus on which is the most useful or the effective for the prediction of the collapse as well as for the recovery. So what is the ideal classification? One which gives the predictability of the future collapse, which is the turning point in the whole treatment of the osteonecrosis. Then it should provide the sufficient treatment guidelines. It should be practical as well as reproducible, and it should have good inter and intra-observer reliability, and it should facilitate the communication among the researchers to compare their results. And it should also form the basis for uniform analysis of the result. Now, there are many classifications. They are based either on the volume, angle, or the location. I analyze following classification of the osteonecrosis: FICAT and ARLET, Steenberg, Michel, Modified Carbon, Japanese Investigation Committee, that is JSC, and ARCO classification, which is the latest to 2021. Now, FICAT and ARLET classification, it actually was the first one we started in 1960, which is initially 3 staging systems. In 1970, the 4th stage was added, and Hungerford and Lennox added stage 0 afterwards. It was finally modified in 1985. It initially included only the X-rays, but later on the invasive diagnostic measures were there, and the MRI and bone scan appearances were introduced later on. It is the most widely used right now also by most of the practitioners. So this is in short about the FICAT and ARLET classification. I won't go in much details because of lack of time. It is from stage 0 to stage 4. The stage 0 is added later, which is the non-clinical also. And stage 1 is the one which is diagnosed only on generally on the MRI. When the MRI of the other hip is taken for the involvement, but primarily grade 1 was not found in the practice. Commonest is grade 1 to 2A and 2B. And after 3, when the collapse starts, there is an endpoint. So before 2A and 2B, we can save or the salvage the head. Grade 4 generally is not discussed in our because it invariably requires the THR at some or other point in the time. There are certain disadvantages of the classification. It relied initially only on the plain radiographs, which are unrevealing the early signs. Rather, it reveals very late. Now there is a MRI, the bone scan has been added into that. But there are no measurements of the actual size of the lesion, as well as whether the articular surface is involved or not. That is not addressed adequately. Then location of the lesion, which is one most important, is not considered in this particular classification. The description of the various stages are ambiguous and overlapping with each other. And all these, it makes it difficult to measure subtle degrees of the progression in this particular classification. So next classification is Steenberg classification, which is also called as the University of Pennsylvania classification, which was initially published in 1984. It is just modified FICAT ARLET, and but it quantifies the femoral head involvement by using the 3D SPGR MRI. It was the first to incorporate the size of the lesion in the classification. It measures the volume of the affected femoral head. It had got some different 6 stages. In each stage is described in the mild, moderate, and severe. And in that, grade A is less than 15%, grade B is 15 to 30%, and grade C is more than 30%. The disadvantage of this is volume measurement is a time consuming, especially if the special software is used. If you cannot use that. And location is also not addressed in this particular classification. This is a classification, Steinberg classification in short. Again, here the same thing. One is a normal, second is cystic changes. Third is actually crescent sign is seen when the collapse is there, but no flattening. The flattening is found, it is the stage 4, and stage 5 and 6 are one which are invariably going for the arthroplasty. There is another Michel's classification, which is the MRI staging classification. It describes 4 classes of the avian based on the signal characteristic within the center of the lesion on T1 and T2 weighted images. These are the classification which is into A to D, A, B, C, D, and this T1 and T2 images, and what is the definition? That is its classification. This classification may be useful for a grading lesion acuity, as infected bone will tend to progress through the classes of the signal intensity over time. However, this progression is not always consistent, and more than one class of signal abnormality may be found in a single lesion. Our next classification is a Japanese classification, that is the JIC classification. And here, this is based on the mid-coronal T1 weighted MR images, which defines the extent, location, and intensity of the necrotic lesion. The extent is the one in area of the coronal image of the involved femoral head, the location which is relative to the acetabular weight-bearing portion, and intensity is the intensity of the signal on coronal T1 weighted images as it was in Michel classification. Several studies have indicated that the location of the necrotic lesion related to the acetabular weight-bearing portion is an important factor for the association of the subsequent collapse. Shimizu, they have found that 74% rate of the head collapse is there. The region involves more than 2/3 of the weight-bearing surface area. So this classification is divided into A, B, C1, and C2. The type A lesion is the one which occupies the medial 1/3 or the less of the weight-bearing portion of the femoral head. Type B lesion is one who occupies the medial 2/3. Type C1 and C2, they are both occupying more than two medial thirds. That is the almost of the lateral 1/3, in which the type C2 extends laterally to the acetabular edge, while the type C1 is below the acetabular edge. Obviously, type A treatment, which is not in the weight-bearing area, doesn't require further treatment. But pre-collapse type 2, if it is even pre-collapse, it warrants immediate attention. It is inevitably going to go into the arthritis. The medially located lesions here, as having the good prognosis, the risk of the collapse is higher if the lesion is lateral, even if the area is in the area small in the volume. So the lateral area is important. It is the simplest method, as lesions are categorized with respect to the mid-coronal image alone. Then it is more reliable and effective, at least in the early stages. Nishi et al. Reported that even if collapse occurs, subsequent cessation of the collapse means there is no more progression of the collapse. It can be expected in certain patients. They observed that this cessation of collapse in patients with small necrotic lesion occupying less than medial 2/3 of the weight-bearing portion, and they found that patients with more than 2 mm collapse, they could possibly still remain asymptomatic, and further investigation necessary to identify the factors responsible for differences between patients with progression and cessation of the collapse. The next is the modified Agrawal classification. In 1974, Agrawal developed a method to quantify the extent of the necrosis. They measured the arc of the necrotic portion on the anteroposterior as well as lateral radiographs, and then calculating the sum of these two angles. Initially, it was based only on the radiographs, but later on, with the development of the advent of the MRI, they modified to incorporate use of the MRI also into this. There is 4 different categories. Grade 1, which is less than 200 degrees. Grade 2 is 200 to 249 degrees. Grade 3 is 250 and up to 299. Grade 4 is about 300 degrees. That is the extent of the collapse they can measure here. They have found that there is a strong correlation between the combined necrotic angle and the risk of the femoral head collapse. None of the small lesions collapsed, and all large lesions they collapsed. And those were the medium-sized lesions, while 50% of them, they within 3 years of the diagnosis, they collapsed. It is very simple and easy to use as compared to Steinberg one. It is more accurate in predicting the occurrence of the collapse than methods of measurement in a single plane. It has a limitation that the diffuse and the patchy cases of the necrotic lesions, they were difficult to calculate. In that particular case, it was difficult to calculate the necrotic angle. Now, the last is the ARCO classification. This is the Association Research Calculation, the Circulation OCS. It was originally created in 1994 and repeatedly revised. The most recent revision was in 2019, which includes the use of radiographs as well as the MRI scan. There is a stage 0 when there is marrow necrosis without reparative process. This is detected. Rather, in 2019, the stage 0 was deleted. And in 2019 new classification, stage 3 was divided into early, that is 3A, and late stage, that is 3B, according to the depth of the head depression. The necrotic lesions which are there, they were reclassified into 3 types. A small lesion where the lateral necrotic margin is medial to the femoral head apex. In the Japanese classification, it was taken as the acetabular part. Here they are taking the femoral head apex. Type 2 is a medium-sized lesion with the lateral necrotic margin being between the femoral head apex and the lateral acetabular edge. And type 3 is a large lesion which extends outside the lateral acetabular edge, which not at the line. So here, a stage 1 is a plain radiograph normal. In stage 2, there is a trapecular bone changes. In stage 3, the crescent sign is seen and the subsequent bone collapse is there. And stage 4 is the one invalid, is the osteoarthritis. In stage 3A, the depression less than 2 mm, it is a 3A. If it is more than 2 mm, it is 3B. It was found that the severe grades or the types of hips such as Steinberg grade 3, modified Kervold grade 4, or JSC type C2 hips had similar collapse appearance times. This is observations. Then, however, some Steinberg grade 1 and modified Kervold grade 1 hips collapsed during the midterm follow-up, resulting in the hip arthroplasty. Small lesions which are confined to the medial or the anterosuperior portion of the femoral head tend not to collapse and thus may be amenable to conservative management. So even in all classification, if it's a grade 1, everybody saying go for the conservative management. And avian that doesn't contact the subchondral margins tend to have good prognosis regardless of the lesion size. Larger lesions with arterial surface involvement are more likely to collapse and they may require replacements. And the prognosis as per type of the operative procedures and the post-op development is not yet observed. Now, we can't predict the progression or its rate right now. The dilemma is this. Second is, what will be the outcome of a definitive protocol of the management? You are starting some management, but what is the outcome? Nobody knows. Even post-operative, after during the surgery, nobody is sure whether the collapse will occur in that particular case or not. And even if the collapse is not there, nobody knows what is the endpoint of the further disease progression which is there inside. And nobody knows when exactly you can declare that the patient is cured or when you can stop the drug treatment and declare that this is burnout. So the conclusion is there is not yet a consensus on which classification is most useful or effective for the prediction of the collapse and recovery. Further investigation and studies might be useful to identify this. Whether each classification system emphasizes specific risk factors for collapse, which classification predicts risk of the collapse. If there is any difference, no classification, it addresses this, that what is the causative factor like steroids, alcohol, COVID, or the sickle cell disease, etc. And especially for the post-operative status, there is no such classification. It's all the pre-operative status. There is no classification, which is the need of the day when I treated the patient. And in my private practice, I use generally the ARCO classification 2021. Thank you very much.
Thank you so much, sir, for a wonderful presentation, specifically making things very much clear. Still, we can't predict, as you say, and we are going to have a long discussion today. Thank you so much, sir. Sir, stop sharing your screen, please, sir.
Yeah, I stopped sharing already.
Now, so fine. Thank you so much. So now we have come into the early diagnosis is important. And now the session is on for the chairs. We are very lucky. Dr. Navaldi Shankar from Chennai Apollo Hospitals. He's a spine and joint surgeon. Lot of experience he has gained from the surgical side. He's here. So we'll start this ball rolling through Dr. Navaldi Shankar, sir. Dr. Navaldi Shankar, are you here? Welcome, sir.
Welcome, sir. Welcome, sir. Thank you very much, sir, for giving the opportunity. And
thank you
so many stalwarts there in front of us. And I welcome you all to the next upcoming Indian Cartilage Society meet happening at Chennai in October 2021. I'll be sending you the details. That's a nice talk, sir. You had started with nice etiology. I just wanted to add one point in etiology. Presently, COVID is a direct causative factors for avian. I think everybody should know it is the cause. Although we are talking about so many causes, the number of avian is double or 3 times or at 10-fold increased following COVID. And without any other causative factors, we found many patients, COVID was one of the causes. And then during the COVID, the second, even if the patient comes out of the COVID, and we had a lot of papers. Initially, they said one of the papers in this textbook of rheumatology, they showed that 2000 milligram was the dosage of prednisolone required to cause AVN. But if you come to the Agrawal paper in British Medical Journal in 2021, they said the mean dose of prednisolone equivalent to steroid taken in a series of post-COVID patients, even 758 milligram is a mean dosage. In this paper, Agrawal in BMJ, he has told even 758 milligram is enough to cause COVID avian in post-COVID treatment. And third point, Madam did definitely discuss the duration of steroids. Yes, initially the papers were suggested in 2002 and all, they were talking about 6 months to 1 year. But again, the latest BMJ, they said the development of avian post-COVID is minimum just 58 days is enough. That's very, very short duration. We are seeing a lot of papers where we see the COVID, the duration of intake of steroids to develop avian in post-COVID. That is, whereas in 2002, they're talking about 6 months to 1 year. But in 2023, we are talking about 58 days. That is the range. They're talking about 45 to 65 days. And many papers in BMJ, I just went through, supporting the duration of steroid required to develop avian in post-COVID. So these are the etiology and duration I wanted to symptoms. Classification, Dr. Karna sir, you really classified really very good. As you said, whatever the classification, everywhere there is a hitch. And this definitely in all the angles, if you say this Corbol, especially when we treat our patients, we definitely use this modified combined Corbol angles, and we see any angle less than 190 degree. That is, you're talking about this combined angle of mid-coronal and mid-sagittal session. If it is less than 190 degree, sometimes we take even in stage 3C, because we know the head is not going to collapse. We have some opportunity to treat it by, whether you're talking about bone grafting, BMAC or cultured osteoblast, whereas a big head, you tend to collapse very often. So that was a thing which we learned in most of the angle. And definitely MRI is definitely now, if you have a good radiologist and good MRI, where they can talk about this crescentric signs or double line images, definitely will let us know where is the lesion, where we can target during the surgery. And this Mitchell's classification has really helped us, because if it's, as I said, if there's a class A, if it is only fat-like, along with the treatment, to stop the fat, we enter, it is going through lipid metabolism, we add something in Agrawal regime, something like that. So, and then in blood-like appearance, we know there's a cavity, we have to do some reverse bone grafting along with our BMAC. And in fluid-like, or if it is a stage fibrous-like, we know that whatever treatment intervention we do, there's a failure. So definitely the radiological classification did make a definitely big change in the treatment of avian. Thank you very much, sir.
Thank you so much, sir. Thank you so much for enlightening us. Such an important point. Definitely, yes, COVID, and now I think everybody will agree. Not only COVID, and rather the COVID peak has been settled down. And as rightly said by you, it is very important. But I'll again have a opinion from Professor Anup Kumar, sir, from AIIMS Patna, on this, that we always see and responsible given to the COVID or alcohol, but basically, ultimately, it's the intraluminal thrombosis which may be precipitated by COVID, because there are many times the patient is not taking any steroid but still is having avian. Dr. Anup, Professor Anup Kumar, sir, are you here? Professor Anup?
Okay. Dr. Manish, I would like to tell you, the COVID was definitely having a hypercoagulable state, and people were developing even gangrene. So then avian is a very small thing. Actually, in micro quantities, it was leading to avian. In macro quantities, it was leading to gangrene.
The only one thing which I observed here is
very
that
true, very true.
This avascular necrosis has occurred after many months of the COVID. Even 1.5 years after the COVID, this has been seen. Now, whether patient came 1.5 years later, which was developed actually at that time, and probably was a dormant, and again it came up. We don't know exactly when exactly this process has started. Whether started during COVID, or whether because after starting the steroid therapy, or whether it started after a few months after that. And what we see is only the clinical presentation, which is a little bit late, and we don't know the rate of progression also. Means it might have started and took 1.5 years for the patient to come us. So that issue is still there.
True, very true, sir. Very true, excellent, sir. Dr. Tanmoy Mohanty, sir, any comments from your side? Professor Anup Kumar, so that we can move to...
Am I audible, sir?
Yeah, Dr. Professor Anup, you are here. Yeah.
About this hypercoagulable state and endovascular thrombosis and all, my personal experience was that my father was suffering, and I was at the receiving end, and we detected it early. He had developed gangrene of the toes.
Okay.
So early, as we didn't have many people going in the COVID wards and diagnosing it, so it was initially a burning symptom only for him. And he himself being an orthopedic surgeon and a general surgeon both. So he was having something in mind that something is going wrong. At that time, he was on BiPAP and his oxygen requirement was very high. And whatever, it was in the first wave. And whatever things were available, we had given him. At that time, tocilizumab and all the remdesivir, whatever was being indicated. But later on, we could find the reason with CT angio. We did it on time, and we could see that at the bifurcation of the common peroneal, this thing, at the popliteus where it bifurcates, there was a huge thrombus stuck there. So then at that time when he was positive also, he was taken into the DSA. The radiologist,
चौथे पांचवें महीने में अगर ब्रेक इवन टेस्ट कर रहे हो अपने खर्चे मत करने लगो तो मतलब ठीक माना जाता है।
I'll request everybody to please mute your mics.
हाँ वो महीने
क्योंकि वहां से भी आते हैं बरेली से भी लेकर वो तो मैंने बताया मेरे घर के पास 4 बजे बस चलती इनकी वो वैन चलती है वो आती है लेके वापस जाती है
आ जाओ।
I'll like to share my COVID experience. Manish.
Yeah.
I'd like to share my COVID experience. Accidentally or incidentally, I was made in charge of a COVID ward. So 1,500 patients passed under me, and I was actually evaluating their psychiatric conditions. But meanwhile, I could notice that 5 or 6 persons had gangrene, as Anup had said, of the toes. One of them had the gangrene of fingertips. Besides avian, I think 6-7 patients came in the orthopedic OPD in medical college for the avian, but all came around after 9 months. Nobody came earlier. Since I was in charge, so people kept on contacting me. So this is my observation, whatever is the reason or analysis.
The avian always reported later on, but that was an acute stage. So we could go in with her, with the help of an interventionist. He went in, and with the catheter, he could cannulate all the whole of the artery till the ankle. But beyond that, it was totally rubbery, and he couldn't remove the clots there. And later on, he ended with a transmetatarsal amputation.
Yes, very sorry, very sorry.
And that was a dry gangrene, and almost we maintained it for almost 2 to 3 months for the clear-cut demarcation to appear without any antibiotics or anything. He was not on steroid, and he was not even a diabetic also. So that was the end result, and we could at least save the limb, just sacrificing the metatarsal and the toes. So that was a close observation what I had. And later on, obviously, as Professor Bhusan also said, patients with avian, they are reporting now, and gradually in different stages, they are coming to our OPDs.
And strange enough, it was all in Delta wave.
Yeah, it was the first wave.
90%.
My father was in the first wave when we didn't have this mucor and all these things. It was early in the month of July only. So that was, and the steroid thing, it's responding high dose steroid. This all was tried in the second wave, the high dose steroids. But in the early one, it was only with remdesivir, tocilizumab, and plasma therapies and all. But I think in that first wave, the doses of steroid was the low dose steroid, and that was also in a very short duration. But the second wave, the duration of the steroid was longer and on a higher dose.
We were doing
our
D-time.
area, in the first wave, high dose of steroids was given.
More the disease was severe.
In our area, sorry. high dose of the steroids was given in the first wave itself. And rather in later stages, whatever patient we are getting that are either in the 2021. The patient who had got in the third or fourth wave, they are not much. But in our area, it's the first and second wave patients who receive the massive doses of steroids. They are coming as a avian one.
And we had reports of upper limb gangrene also. Means in some of the.
That's what I said. 2 cases, fingertip gangrene.
It seems that where the vascular blood supply is already compromised, there probably in those patients it is getting far more, especially the distal necrosis.
Because of the severity and requirement of the oxygen, everything was means targeted towards the lung for the therapy and all, but somehow we were missing that, which was detected on a later day.
Very true. Thank you so much for this interesting part of the COVID, which is now little bit of off, but still, let's say what you have told, Dr. Karne, still we are seeing such patients.
And different spectrum also means not only avian, maybe later on we'll find more different presentations.
Very true. Very true.
It's still early to predict.
But have you found any difference in the event due to COVID and all the previous factors? Have you found any difference into this presentation? Because you are not able to detect whether there is a difference in either sickle cell anemia or the common alcohol or the steroids. There is not yet much change as far as clinical presentation is concerned.
Yeah, but the numbers have definitely gone up.
Number 10 times number.
Yeah, that's true. That's because we don't have the pre-COVID data that how were they behaving and what was the presentation means.
But definitely, yes, with the COVID, the entire head has been involved most of the time. And in most of the cases, the prognosis is not very good because if the head is involved, how much to do the decompression and how much the graft is a challenge, truly speaking. That is definitely a thing which we all have seen and appreciated.
And a thing will be important to see if we do we are doing decompression for these patients. How is it behaving? That is also an important thing to observe. I think that would be a
very true. Very true. So we will be having a separate topic on this also. So with the permission now of all the chairs, we'll now go for the next session. That is management, how to proceed, for which we have already started right now. But yes, the management is a very important thing which needed to be addressed at this stage. But for this, definitely we'll just sum up everything together as a part, as a scene from a nuclear medicine specialist, from a radiologist. Thank you so much, Dr. Nagesh, for joining us here. He's a radiologist, and he will be just giving its best for what worked best actually for the imaging modality to be considered, as we were just discussing right now. Over to Dr. Nagesh. Dr. Nagesh? Yeah. Dr. Nagesh, your mic is muted. Please unmute yourself. We can't hear you. Dr. Nagesh, we can't hear you. Please unmute yourself.
You can unmute him as an admin.
Sir, am I audible?
Yeah, you are audible. But we can't see your
sorry.
We can't see your screen. Okay.
Yeah. Okay. So basically, I am Dr. Narvesh Kumar. I was I did my MD from Sanjay Gandhi PGI Lucknow in 11 to 14. Then I was senior resident over there. And I was heading Apollo Hospital Lucknow from October 2018 to 2023. In April 2023, I quit from Apollo and I started my own setup. This is Sanya Scans and Theranostic in the Gomtringa area in Lucknow. And I am listening all the lectures from last 1 hour, and it was quite interesting that everybody was sharing their input from the radiology to pathology to classification. So in nutshell, I will start I will finish my this session in 8 to 10 slides. Basically, I will talk very precisely. Due to lack of time, it is only 7 minutes. So as we all know, the osteonecrosis is a generic term for the ischemic death of the bony tissue. And basically, the two terms, the osteonecrosis and the avascular necrosis, both are interchangeable with each other, and they are interchangeable. And right now, osteonecrosis is being more used, and it is general and inclusive term. And now, preferably, we use this in place of avascular necrosis. So, as we have already discussed in the pathology section, the infarction begin with the blood supply of a section of bone is when the blood supply of a section of bone is interrupted. Then, in that scenario, the infarction of that area begins, and the cells will die, and the further there will be lack of blood supply over that particular area, and it will create the infarct. And most of the time, if it is in the subchondral region, then we call it the osteonecrosis. And if it is in the cortex area, in the medulla area, then it is the infarct. So the etiology, already ma'am has discussed about the etiology. There are multiple factors which are creating the avascular necrosis. The most common is like trauma, and there are multiple other causes like hemoglobinopathies, pregnancy-related osteonecrosis, radiotherapy, and many more. So I will not go in the detail for this etiology, as we have already discussed about it. So now come to the main topic. So how we will proceed in a case of this osteoradionecrosis or avascular necrosis? Basically, the patient initially complained with the pain, and the patient will present to the clinician, and there will be some clinical examinations, and there will be a clinical diagnosis of the patient that this patient is on the basis of the history of the steroid and on some trauma or some other things. Then the clinician will decide that yes, there is a suspicion of osteonecrosis or avascular necrosis. Then they will prefer some tests. So the common used modalities which we are using in this osteonecrosis are X-ray, and CT is not much useful, but we can use it to see the 3D reconstruction of the surface of the affected area. And the commonly used investigation is the X-ray. But in the early phase, as we all know, that there is no bone loss, there is only mild edema or some necrosis in subchondral area. The structure is not disturbed, so usually X-ray is not a good modality for the early diagnosis of the avascular necrosis. So basically, the modality of choice is the MRI, magnetic resonance imaging. This is the highly sensitive and specific modalities. It has a sensitivity and specificity of around 90%. And the next modality which will be useful, that is the bone scan. What is bone scan? Bone scan is a radioactive material, technetium-99m, and when we add it with MDP is a radiopharmaceutical which target this technetium-99m towards the area where the osteoblastic activity is quite high. So if the osteoblastic activity will be high, then it will fix over there, and through adsorption over the bony of the cells on the cartilage, and it will give us the signal from that area, and we will record it through the gamma camera. Gamma camera is a machine on which the patient will lie down, and the patient will pass through that machine, and from the body of the patient we will receive the signal and from the images. So I will show you in the next few slides about all these images. So as I was already discussing about it, that X-ray is the plain radiograph and are negative in early disease because there is no structural abnormality in the early time. So the X-ray are mostly negative. And in initial time, there is only mild osteopenia followed by variable changes such as patchy sclerosis and rim calcification. Gradually, there will be microfractures of the subchondral bony region, and the bone will be dead, and there will be some anatomical changes, and then we can see some signs like crescent sign that is specific for osteonecrosis. So the X-ray are useful for the later stages, not in the early stages. And for the MRI is the most sensitive. Am I audible to everybody?
Yeah, you're audible. You're slightly more stopped.
Yeah, thank you. So, as we were discussing about the MRI is the most sensitive modality and demonstrate changes well before plain radiograph change are visible. Like it can see the very early changes in the form of mild osteopenia and in the form of edema. So we can pick it very early. So MRI is the modality of choice. And there is a reactive interfaced line on the T1 images. We can see the focal serpentine low signal line with fatty center, most common appearance and first sign of the MRI. जब हम MRI करेंगे there could be multiple sequences. तो जो common sequences जो हम लोग use करते हैं that are the T1 weighted and T2 weighted and fat set images. So in the T1 weighted images, as we can see in this image, this is a subarticular area of the humeral head surrounded by hypointense line on the T1 images. This is the hypointense line on the T1 images with high signal intensity on the fat set line. Like अगर हम इस वाली इमेज में देख रहे हैं, this is the T2 image, and in T2 image that we can see that there is a high signal intensity and this line is more intense, and in T1 images this line is hypointense. So this line is quite specific, and the area which is affected is hyperintense in T1 images and hypointense in fat set images. So we can see this is the classical image for the avascular necrosis of the humeral head. So MRI is commonly used in the early detection of the avascular necrosis. When MRI is inconclusive, if there is a doubt over the MRI also, and we are not able to make a diagnosis on the MRI also, in that scenario, bone scan is quite helpful. Basically, as I was telling you that in bone scan, we use a minute amount of tracer, and that is called 99M technetium MDP, and we do triple phase bone scan. Triple phase में मतलब क्या होता है कि in the first phase, we image only that targeted area. Like if we are suspecting for the AVN of hip, then we will take the images from the hip region, and in the triple phase, first phase is to see the blood flow in that area. Second phase is to see the soft tissue in that area, that soft tissue is inflamed or not inflamed, and the third part is to see the bone only. So we put the patient on the gamma camera, and under the gamma camera we inject IV the technetium 99M MDP, and we take the images from the affected area. And for the first phase, when the patient is under gamma camera, then we can see that the perfusion of that particular area will be low. So we will see just like this MRI image on the bone scan also, we will see that there will be an area, white area, we call it bull's eye sign. In that area, there will be no uptake. And on the surrounding area from where the supply is cut, we can see the increased test uptake. So it will be quite helpful to see in the very early stage when we are suspecting for the ABN, and if MRI is not helpful, in that scenario, we will go for the three-phase bone scan to see that the blood supply is there or not. What is the impact of that blood supply on the bone on particular that area. And now also we are going on the SPECT CT. What is SPECT CT? SPECT is basically 2D image or 3D image of that particular affected area, and the CT is associated with it. So we will see the SPECT, that is the functional imaging, and CT, that is the anatomical imaging. So SPECT CT a complete modality where we can see, yes, blood supply is less in that area, and on CT we can see that what is the status of the structure, and the surface is maintained or not maintained, then there is subchondral cyst or subchondral some kind of changes over there. So we can detect on the CT also. PET CT is not commonly used for the AVN, but SPECT CT and bone scan are commonly used. So this is one more image. Here we can see this is the avascular necrosis of the this head of femur. This is the MRI of T1 image. This is the PET sensitive image we call it, and here we can see a hypointense area, and there is a hyperintense island which is being affected in the subchondral region. And this is again the fat set image or still image. Here we can see that there is just opposite to it. This is a more pictorial presentation, but on the real images, we will see a hyper intense line over here, and this area will be hypo intense. So this is the edema area, and this is the sclerotic area. So double line sign is a classical feature to find and to diagnose the ABN of the hip or osteonecrosis of the any region. So rim sign, and the osteochondral fragmentation and secondary degenerative changes, osteoarthritis, or multiple other structural changes. We can see those changes also on the different sequence of the MRI. I have already told about the nuclear medicine, about the bone scintigraphy, which I was discussing. The three-phase bone scintigraphy is quite helpful. So bone scintigraphy is quite sensitive. Its sensitivity is around 85%, and this is the second option after MRI. When MRI is inconclusive, when the MRI is inconclusive, then we will go for the bone scan. So the findings are different according to the time of scan. In the early disease, often represent only a cold area that reflect the vascular interruption is there, and in the late stages we may see a donut sign, a cold spot with surrounding high uptake ring. So as I was already telling you that donut sign or bullseye sign will be there in the later stage of the disease, and early stage of the disease there will be only a low intensity area. So conclusion is osteonecrosis can occur. Osteonecrosis can occur at any bony site. There are multiple causes of osteonecrosis, and MRI is most sensitive modality, followed by three-phase bone scintigraphy. Thank you so much.
Thank you so much, Dr. Naveen, for a wonderful presentation, enlightening specifically for the bone scan and those aspects which we sometimes require when there is a dilemma. So I beg your pardon, I was not able to introduce the chairs of this session. So we welcome Dr. Raghunandhan from Chennai. He's a sports person from the Rathimid Hospital. He's an excellent surgeon doing a lot of work on the regenerative orthopedics. And at the same time, welcoming Professor Sandeep Srivastava from Wardha Medical College, JNU Medical College, Wardha. So with the permission of the chairs, we can move to the next topic. Anything which you, Dr. Raghunandhan, you want to say, since we have interrupted in between? Otherwise, we can take everything in the end also. Dr. Raghunandhan, are you here? Fine.
I think we can take it up at the end of the session.
Fine, fine. Thank you so much for this permission. So now, finally, the managing part. After one and a half hour or 1 hour 15-minute discussion. So we'll request for the conservative management, Professor Alok Agrawal from AIIMS Raipur, to have the insight. He's the president of Indian Stem Cell Study Group Association, for the insight about the management part. But I'll take your permission, Alok sir, to just share my screen first of all, if you'll just allow me to go. Yeah, I'm doing. Okay, fine. So I have not placed anything specifically. So I'll stop sharing it right now here. Over to Professor Alok sir. Yes, sir.
Thank you. So let us discuss the medical management of osteonecrosis of femoral head. The hip salvage modalities aim at...
Sir, we can't see your screen. In fact, I'm not able to see maybe.
You're not able to see my screen?
I think the screen is not shared.
Please share your screen first.
Initially it was coming, but now...
Yeah.
You have given a share screen option. Is somebody also doing something else?
Oh, just a second. Maybe I am the culprit for this. I'm responsible for this. Yes. Yeah, it's a fault from my end now. You can start sharing now. Yeah.
Just slideshow.
Yeah, please move over to slideshow.
So can you see the slides now?
Yeah, please go for the slideshow, sir.
Should I start?
Yes.
So you can start, but actually we are not able to see the slideshow mode. If it is possible, otherwise we can go like that also.
Okay, now is it okay?
Yeah, it's visible, sir. Just go into the slideshow.
Actually, I had gone in the slideshow, but then whole screen goes off and you people also go off. I don't know.
Okay, son, fine. We can go ahead like this also.
You can start with it.
Yeah, please. Don't
I'm at Kolkata. I'm sharing someone else's computer.
सर क्या ऑनलाइन कॉन्फ्रेंस थी कैसे?
हाँ.
इसके
I'll try once more.
I'll request everyone to please mute your mics, sir. Requesting everyone.
हाँ राहुल.
Yeah, thank you so much.
नहीं, उसका बिल रेज करके वो उसी ग्रुप में जो बिना को बोलो, जो ग्रुप में जो बंदा है उससे बात कर पूछे अकाउंट सेक्शन फॉर्च्यून हॉस्पिटल में जाएगा. 16
Let me
16 पे होगा.
चालू करें.
Mute yourself.
I think you can yourself mute all the mic.
Yeah, you can.
Yeah, fine. Yeah, Alok sir, please go ahead.
Fine. So the hip salvage modalities aim at reversing or halting this pathogenesis in the pre-collapse stages only. This can be non-operative or surgical. Non-operative management includes restriction of weight bearing, that is use of canes and support, drug therapies, and biophysical interventions, including electromagnetic and extracorporeal shock waves. The basic premise of non-surgical management is to provide relief from the mechanical pain and prevent disease progression. So you can see all the three. If a patient bears weight with AVN, it will get collapsed. The medical management goes with biophosphonates, statins, anticoagulation therapy, and vasodilators. The biophysical management therapies include extracorporeal shockwave therapy, pulse electromagnetic wave therapy, and hyperbaric oxygen therapy. Non-weight bearing, in the early form of unilateral disease, there will be a necrotic patch being relatively small, less than 15%, then you can use it. Patients can be advised against weight bearing and walking with support of a cane or crutch held in the opposite side. This should not be in isolation, as invariably the disease does progress, and there needs to be additional modalities provided to the patient frequently. We have been giving patients weight relieving calipers with biphosphonates for 2 to 3 years, and the results have been good. So coming to biphosphonates, well, they inhibit the osteoclastic activity in the osteonecrosis lesion site and thus promotes bone healing. They prevent the onset of subchondral fracture or collapse.
Sir, Alok, we cannot see your screen.
You can still not see my screen?
Neeraj, we lost it and you have to make it full screen.
Can you see my screen now?
No. Sir, you have to come out and again put the share back again. You come out and again.
Manish sir, you don't do now. I will share only me.
Sir, we can't see actually. Just come out and again try to do. Maybe it works, sir.
Yeah. Kindly make it full screen.
Okay, now?
Sir, kindly make it
we can see. We can see.
So keep on telling me till you can see, then I will again do the same thing. So biphosphonates inhibit osteoclastic activity in the osteonecrosis lesion site and thus promote bone healing. They prevent the onset of subchondral fracture or collapse in early osteonecrosis of the hip, and in advanced conditions when already collapse has occurred, it delays the need of total hip replacement. People prefer combination therapy of zoledronic acid and alendronate. Zoledronic acid in the standard orthopedic dose, 5 milligrams per year, and alendronate 70 milligrams weekly. People have different views for ibandronic acid, although the Chhattisgarhi patients, they love ibandronic acid and the results are good. Oral weekly alendronate treatment has been shown to prevent collapse in 70% of the patients after 3 years of continuous course. There has been a paradigm shift in osteonecrosis treatment with biphosphonates. In this study of Dr. Sanjay Agrawal of 20-year study, he has shown that a combination therapy of 35 milligrams of oral alendronate twice weekly and 5 milligrams of intravenous zoledronic acid once annually for 3 years was better than 10 milligram oral alendronate daily for 3 years. Here you can see an X-ray. The AP radiographic presentation is showing stage 2 osteonecrosis. The T2 weighted MRI presentation is showing a small sector of osteonecrosis and bone marrow edema, the yellow arrows.
We can't see the X-ray.
We can
Sir,
see
your
the
X-ray is not seen.
Again, you cannot see.
No, sir.
So then, Manish sir, I had sent you the slides. Can you upload?
Okay, so I'll need to have the time for this. Can we go for the next presentation? Meanwhile, I have to take it out, sir. To...
You can send me now. I will upload immediately.
Okay, fine. Alok sir, can you send? Have you sent on the mail to me? Professor Alok sir.
So I had definitely shared with you.
Yeah, I know.
I know. WhatsApp also. We can do it immediately.
Just a second. Meanwhile, can we have some discussion on like alendronate and zoledronic acid you are saying combined? So what make it relevant in that way? Because combining two bisphosphonate together, Dr. Alok, what do you say about that?
There was a study by Sanjay Agrawal who has done this by combination therapy, and he said
that WhatsApp also.
Yes, sir, I'm just collecting it.
Just now on WhatsApp.
I had one query, Dr. Alok. Now you said, I think there's some disturbance from Dr. Bhusan. Can you mute Dr. Bhusan, please? Can you mute Dr. Bhusan, please? Well, Dr. Alok, I had one query. You had said that the bisphosphonates, it promote the healing. Okay, because it's, but if it, for the healing purpose, the dead bone has to be removed. And then only the new bone will be formed over the dead bone. And if you are starting the bisphosphonates, it will stop the osteoclastic activity and there will be, dead bone will remain just like that. Bisphosphonates are known to cause vertical fractures. So how bisphosphonate is going to promote the healing, number one. And number two, as you said, that how it will prevent the subchondral fracture. It is not the one which is causing subchondral fracture. The subchondral fracture appears because the dead bone which is there, below that is a new bone formation occurs, and that new bone formation is very weak. And that's why the whole thing collapses down. So it is not the bisphosphonate which can stop the collapse. Whatever is the mechanism of stopping the collapse by the bisphosphonate. Rather, bisphosphonate is not helpful even in the initial phases because it's the bone, the death of the bone, and death of the bone will not be prevented by bisphosphonate, number one. Number two, once the reparative process starts, there the dead bone has to be removed, where the bisphosphonate will be hinder that. They will not prevent, they will not allow the dead bone to be absorbed. So how bisphosphonate is helping in both ways, either in the initial phase or in the later phase, in the reparative phase.
So I'll show my slides again and then explain it to you. Manish, put my slides, please.
Just, I'm just doing it right now.
One more point I wanted to speak about the previous speaker. He said osteonecrosis, because it was found that there may be a different cause other than the ischemic cause. Because the ischemic cause, it is called as a vascular necrosis or the infarction. But the word osteonecrosis has come because it's not necessarily ischemic cause. It can be other cause also. So the better word was osteonecrosis than the vascular necrosis. That's my comment.
And that is understood by the terms only. Avascular means without vascularity.
That is one of the biggest pathology we can say, but there can be other pathologies. So instead of using avian, use the word osteonecrosis.
Is it visible, sir?
Yeah, it is visible.
Which slide, sir? More?
No, go a bit back. Yes, next.
Yes, Manish, wonderful.
Please, thank you.
Yes, wonderful. Ekdam first class hai.
Yes, sir. Professor
next
Alok.
slide.
Yeah, go ahead.
Yeah,
Go
sir,
ahead,
you can
please.
hear me now. Now, next
Thank
slide.
you, Manish.
Okay.
Next slide, please. So it is it here.
Sorry. Yeah.
Biphosphonates inhibit the osteoclastic activity in the osteonecrosis lesion site and thus promotes bone healing. It prevents the onset of subchondral fracture of collapse in early osteonecrosis of the hip and in advanced conditions when already collapse has occurred. It delays the need of total hip replacement surgery. These are the two uses. Next slide. So this we had already discussed. Dr. Sanjay Agrawal says that 35 milligrams of oral alendronate twice weekly with 5 mg of intravenous zoledronic acid once a year gave better results at 3 years compared to only alendronate. Next slide. So we were discussing here diagram C, the AP X-ray at 1 year of follow-up showing stabilization of the osteonecrosis and T2 weighted MRI at 1 year follow-up showing complete resolution of the bone marrow edema. So on the top, you can see that how the damage was happening. And this is after 1 year of biphosphonates. There you can see the repair. The edema is subsided. The head is maintained in sphericity. Even the X-ray showing a better picture. Next. Coming to anticoagulants, statins, and other vasodilators. The hyperfibrinolysis and thrombophilia leading to venous stasis and reduced arterial flow, thus cause increased intraosseous pressure and hypoxic bone death. And they have been postulated as a major and common etiological factor for osteonecrosis. Systemic anticoagulation therapy started before irreversible segmental collapse of the femur head may arrest or speculatively sometimes reverse the process of ischemic osteonecrosis. Anticoagulant therapy has shown benefit in these some small studies and has prevented the progression of osteonecrosis from pre-collapse stage to advanced stage in idiopathic osteonecrosis or corticosteroid-induced osteonecrosis. Next. Lipid-lowering agents are also helpful in osteonecrosis, especially due to steroids. Steroid causes hyperlipidemia, which increases the fat content of the femoral head. It increases intracortical pressure and leads to sinusoidal collapse and osteonecrosis. Statins are lipid-clearing agents that dramatically reduce lipid levels in blood and in tissues. That is what is thought about. Next. So here is a paper on clinical orthopedic and related research 2001, where they showed that statin therapy decreases the risk of osteonecrosis in patients receiving steroids. At a mean follow-up of 7.5 years only, 1% patients who were taking high-dose corticosteroids and statins developed osteonecrosis of femoral head, whereas the prevalence was 3 to 20% in otherwise. So this is a very good paper, and I feel that in the COVID era, if statins were given along, maybe the incidence would have been less. Next, please, sir. Another paper by Ajmal, who did not find any significant reduction in osteonecrosis between patient taking steroid and statin versus steroids without statins. Next slide, sir. Iloprost, a prostacyclin derivative vasodilator, has also shown benefit after 1 year treatment in patients of osteonecrosis and bone marrow edema. Adrenocorticotropic hormone has also shown protection against osteonecrosis induced by steroid. The proposed mechanism of action of this drug is based on enhancement of osteoblastic activity and stimulation of vascular endothelial growth factor that enhance neovascularization in the femoral head. Next, sir. Coming to extracorporeal shockwave therapy, well, the mechanism is unknown, but it is believed that it enhances neovascularization by stimulating the expression of angiogenic growth factors. Next. Pulsed electromagnetic wave therapy also brings stimulation of osteogenesis and angiogenesis similar to extracorporeal shockwave therapy. Masari, in the retrospective analysis of 76 hips treated with electromagnetic field stimulation in stage 1 and 2 PICAT, reported 94% of the hips they did not have to operate with the THA, and that was significantly higher for other patients. So this is quite good that some patients were saved of THA. But at present, evidence in favor of electromagnetic stimulation is limited, and further research is needed to explore its potential role in early stage osteonecrosis. Next. Manish, the next slide.
Sorry, this is the next slide, sir.
Yeah. Coming to hyperbaric oxygen, well, more and more people are purchasing hyperbaric oxygen beds, keeping patients into them for various orthopedic disorders, wounds, crush injuries, and now for avian, and they are finding good results. Hyperbaric oxygen is found to be improving oxygenation, reducing edema by causing vasoconstriction, and induces new angiogenesis, a reduction in intraosseous pressure, and improvement in microcirculation. Rees et al. Observed normal MRI in 13 hips after hyperbaric oxygen treatment. That was 100% oxygen at 2 to 2.4 atmospheric pressure for 90 minutes by mask for 100 days. To 12 patients with 16 osteonecrosis of femoral head, all with Steinberg stage in 1 disease. Camporisi et al. Also reported clinical improvement at follow-up of 7 years in the study of 19 patients who were randomized and treated with hyperbaric oxygen for 6 weeks. Well, none of the hyperbaric oxygen groups patients needed total hip arthroplasty till the time of their final follow-up. But this data is limited, so we cannot say. But there are now more and more centers coming in India also who are giving hyperbaric oxygen therapy to treat avascular necrosis. So next. So sir, this was in brief about the ways in which medicines and physical measures were helping out in the management of osteonecrosis.
Thank you so much, Professor Alok sir, for a wonderful in-house everything together. And with the permission of chair, I just want to start before moving to the surgical topic, surgical choices, to finish this medical part, discussion part here, and to roll the ball. Just what we have summarized this early evening is ultimately for an avian head of the femur, what has been required is to prevent the death of osteocytes. Now, the preventing the death of osteocyte, of course, we have to go for removing the causes, but a creeping substitution is important. But as pointed out by Dr. Karne sir also very rightly, creeping substitution is important for throughout the phase of healing, but ultimately osteogenesis and angiogenesis is required to gain that head. So can we put some inputs on this bisphosphonate, because there are so many school of thought working throughout the country, around the globe. Even at some regimes, they don't use bisphosphonate, thinking it that yes, it has not been required. But for me, it's to some extent, what I believe is bisphosphonates are important in early stages because we have to minimize this osteolysis, absorption of the osteocytes, so as to give the chance for the natural way of healing for a formation of a reparative network, which we all know. Any comments from anybody on this?
Dr. Magoo, this side. A lot of work is going on AIMS, New Delhi, with Dr. Mittal on bisphosphonates' role in avascular necrosis. And I have also seen that when there is stage of edema, maybe simple drilling or bisphosphonates play a role. Dr. Mittal told me that bisphosphonates are a good pain reliever. They reduce edema, correct the edema. And he says, in any case, collapse has to occur. If patient buys some time for a THR, that is the reason he is using bisphosphonates with a good follow-up, he says. I have seen good number of patients. Of course, I also use bisphosphonates with great respects to Professor Agrawal, I'm also using this zoledronic acid, but I do feel that in stage 2 at least, or particularly when there are subchondral fractures, the bisphosphonates have no role, and there is bound to collapse in such a situation. But Mittal's comments are very important. I also told him, why don't you use zoledronic acid? He says, it's not an OPD procedure. This takes 1.5 hours at least to infuse zoledronic acid, and patient has to be admitted and he has to be under care. But I do value his comments, because I'm seeing that for the 5 to 6 or 7 years, he is using bisphosphonates in the management of osteonecrosis, and he say primarily it is a painkiller.
Can I comment, sir?
Yeah, definitely, Dr. Karnit, sir.
Yeah,
These are not my comments. These are the
sir.
comments of the workers who are regularly doing it.
Sir, Dr.
And I do give weightage to it.
Yes, sir.
True.
Now, one comment about the hyperbaric oxygen just now, Mr. Dr. Alok has presented. See, it was done on the Steinberg type 1. In any condition, whenever, as you also said, that only when edema is there, that is almost stage 0, you can say. And even when there is a necrosis, is stage 1. In the stage 1, you do any kind of therapy. You know, the patient, all persons who are using therapy, right from there is one paper only on the injection teriparatide, that he has used only teriparatide and he has got excellent results. Okay, nothing, no other medication. There is another group which has used only anti-inflammatory agents or anti-rheumatoid agents, and other they are using for more than 15. Dr. Mukherjee himself using more than 15 years, and rather with a low dose of the methylprednisolone, he's using that very low dose of the methylprednisolone. Still, he is having excellent results. So whether when we are giving bisphosphonates, and still I have seen many patients with the bisphosphonate therapy, ideal therapy, combined therapy, and has got from grade 1 it was started and they have reached to grade 4 and the arthritis. So what we have to take this with a pinch of the salt, number 1. Second thing, we have to understand, we just should not go like that. I have started bisphosphonate, patient has got good relief. How we should know the mechanism of the action of the bisphosphonate. They do only osteoclast inhibition, and whether the osteoclast itself is the cause of the pain. Osteoclasts are the one. See, one thing is initially the bone is dead, as far as the osteocytes are dying, so the bone becomes dead. And second, that has to be revascularized with the osteoblastic activity, osteogenesis, and the angiogenesis. In all these things, where the bisphosphonate help. So whether giving bisphosphonate is giving the same result, as you said, Dr. Mittal, why he is disappointed? Because he is using only bisphosphonate. So whether you are using only bisphosphonate and analgesic along with that, so that the pain relief is there, how exactly the bisphosphonate acts, that is my dilemma. Because the basic mechanism of action is just inhibition of the osteoclast. And are the osteoclasts in this particular disease are the culprit or the villains? That is about bisphosphonate. We'll talk about other medical management later on. Let's have a discussion on the bisphosphonates.
True, very true, sir. And I want to add again, Maghu sir, on this. TNF-alpha interleukins, they are being there, and they are basically causing the osteoclast activation. So if osteoclast activation is inhibited, the pain will go away. So there are so many unanswered things which is coming up gradually over the time. So what is being used for these bisphosphonate, they inhibit osteoclast. When they inhibit osteoclast, so the osteoclast activation is not been there, so automatically the pain will come down. So that is the thing into it. What is it? Yes, Professor Karnit sir, Kiran sir, Sauji sir, sir.
I just want to ask to Dr. Alok. He said hyperbaric oxygen helps. So my understanding is hyperbaric oxygen helps in open wound. How it helps in avian? That is my understanding. I may be wrong.
Professor Alok sir, are you here? I think I'm receiving his call from.
I will answer, Dr. Kiran.
Yeah, Dr. Alok.
Alok is there. Okay, yeah.
Sir, good evening, sir. Dr. Alok sir is actually, I am in ESIC Joka. So one program is going on. So sir has gone there to the lecture.
Welcome, sir. Yeah, welcome, sir.
So he was connected with my computer in Dean's office. So,
hyperbaric oxygen is the one which increases the oxygen content.
Back after 5 minutes.
Okay, hyperbaric oxygen is the one which increases oxygen saturation in the blood. Very simple. It does nothing else, right? And so where there is ischemia, whatever oxygen which goes by the normal circulation, that percentage of the oxygen goes higher. That's why the wound healing helps. It is given for the bone healing also. It is given for multiple reasons. But here also, if there is ischemia, probably hyperbaric oxygen might be helping that. But do we have any more better modalities which will help there? Because there are n number of the modalities which help the increase the blood supply and to increase osteogenesis. But we have to find such a modality which has got a better action of both the things. So one is doing some of 10%, the others are doing 90%. So are we going to just hold 10% and see, this is watched by many doctors and all are doing this. So we should give such a message that next day they will go in their OPD or in the hospital and will start using these modalities. So we have to see critically every modality which is used. As you said, sir, when an anti-inflammatory, that inflammatory is a promotion of the osteoclast, but at the same time, anti-inflammatory, these inflammatory modulators itself, they can cause a pain. So without taking osteoclast into consideration, the anti-inflammatory medications which is proposed by Mukherjee are inhibiting those TNF alpha factors. So where osteoclast may not be there, only you control TNF and you are getting just like mild arthritis and you will get a pain relief.
True, because ultimately the angiogenesis and osteogenesis is required.
That is important. That is in the next phase, that is reparative phase.
That is, so we
stop the dead necrosis and then let reparative phase.
I think so, Manisha.
Yeah, so we can go to Professor Sauji, sir. He wanted to have a comment. Yes, sir. Professor Sauji, sir.
I just asked that question. This, my understanding is hyperbaric oxygen helps in open wound. You have to keep limb in the hyperbaric chamber and then it helps. Dr. Karne says it increases the oxygen saturation.
Ultimately, we are all surgeons and what we are doing is increasing oxygen by hyperbaric other way, but otherwise the core decompression, all the things which we are going to discuss. So ultimately, yes, bisphosphonate, and truly speaking, somebody at some places, they have used bisphosphonate initially and later on even a teriparatide, but provided the collapse has not been there. And the cause of the collapse is the reparative zone also, which we miss sometime, and we make it responsible everything to the bisphosphonate. So I think with the
can I add on one thing?
Yeah, please. Yeah.
So like we are talking about bisphosphonate and AVN, now there is a word of caution that if you give bisphosphonate irrationally and following it for a core decompression, I don't know how many cases you have done about experience about it, but persons who have undertaken alendronate or zoledronic acid and following it with a surgical procedure, it's very tough. The bone gets so sclerotic. So we need to somewhere keep in mind there is a reparative process which is going on. There is a certain etiology which is causing this osteonecrosis, and without determining the fact that what is the etiology, probably using medical management blindly may not help us. So we need to find out data. For example, there is a lot of discussion about antiplatelet statins as well. I think so they have a role to play. So we need to understand that there is a microembolism which is going on there, which is killing the cells, and if we need to do some reparative process, then we need to focus on etiological process also, not only on radiological and staging.
One point which is there, that in stage 1, when we don't go for surgical management, medical management should be done. When it goes to stage 2, probably surgical intervention either in form of core decompression with the use of orthobiology,
very
along with medical management in the post-op period.
For the stage 2, it is very important.
I could not hear you. We lost
stage 1, but unfortunately, very unfortunately, what we see usually to Dr. Magoo sir, everybody knows, sir. Magoo sir, please share your screen. So we can now definitely going to work up with core decompression, with the Finister grafting, with the reverse grafting, with muscle pedicle grafting, or different modalities. Ultimately, the aim is angiogenesis plus osteogenesis. And the core decompression itself is going to relieve a lot of pressure, decreasing the pressure on the head, which will again have a breakage of the vicious circle. Over to Dr. Magoo sir, reverse bone grafting. Sir.
Am I audible?
Yes, sir. We can see.
Yeah. The important thing which I want to impress upon what Dr. Karne also said. You have to remove the dead bone.
You are perfectly audible, sir.
You have to remove the dead bone to invite neo-osteogenesis or neo-angiogenesis. That is my concept. That is what I think.
Perfect, sir.
And for that, a surgical technique is very important. Now, Fickett used in 1960 this 6.5 mm or 6.8 mm drill. Pressure releases in the medulla, but bone is not removed. Bone grafting techniques have come up now, and they say that in stage 1 and stage 2, a very useful procedure could be vascularized, could be non-vascularized. I'm not going to talk because topic given to me is reverse bone grafting. So this is the graft taken from the trochanter and the head that has undergone a osteonecrosis in a bone awl. We have just reversed it through 180 degree, and that is called as reverse bone grafting. The live graft we put into the head, and the dead graft we take it towards the trochanteric area. That is reverse bone grafting. We put a drill. That is the area. You see, it is dense. Contour must be maintained, I tell you. Whether you do drilling or you do reverse bone grafting, the contour of the head and joint space must be excellent. So this is 1, this is 2, this is the hollow mill, and that takes the graft from this 1 centimeter short of that. Otherwise, you will invite again a collapse. So that is white is dead, and that is the live, osteogenic, I should say. Again, same. This is the track formed. This is the track formed. And I tell you one very important thing, what I have observed in my practice, that if you combine it with an osteotomy, stage 2 and stage 3, combine it with an osteotomy, it works wonders. Because Alok's had calipers, weight living, and that is what we have been teaching conventionally since our teacher taught us. Bete chadi leke chalo, walk with a stick. So debride the bone, graft the bone, and if it is mild collapse or subchondral fracture or stage 3, must rotate it. That gives a surgical rest to the bone which has undergone AVN. That is the bone which I have other sample, stage 2. Now take a DHS reamer. It is short of 1 centimeter here. Don't weaken this area. That is the, now you can take out the wire and put the grafts. And before that, this is a surgical knife. It's a very good, I should say, debriding instrument. So you can make it a U shape. You can retrace it and you can go ahead, and this beautiful track is formed. And then you put the graft that you have taken. That was the graft. So this is the track. And this is the graft which you have actually taken from trochanter and have placed it in the head area. So once you have done this, you have removed the dead bone and put almost nearly, I don't say it is live, but still it is live. It is osteogenic. It is cancerous bone, fresh absolutely. So that initiates angiogenesis and that prevents collapse. People say they put weight bearing. No. I still keep the patient non-weight bearing for 6 weeks, at least 6 weeks he should be on walker. That is very important again to prevent the collapse. So here at times I put fibula, but now I saw infection in one case because ultimately it is just a sport. It is a stud graft. Now I have stopped doing it, but this is the graft which at times I use when I feel that some area has weakened. And this is, again, I should say, some collapse is there in this. So once collapse is there, actually is contraindicated, but still I debride it, but then I rotate it and put a plate, do a flexion osteotomy or a derotation osteotomy. But I observed if patient's weight is less, particularly I have seen some females, and it is early stage 3 where you still find subchondral fracture, this kind of a decompression with the bone grafting with debridement still works at least up to 5 years. Now this is what I observed. I have rotated this area with the valgus osteotomy, I have debrided it, I have grafted it. So the moment I put a chisel here, the grafts are lifted from the calcar region. So this whole area, which was empty, is filled up with the grafts. So that is again live osteogenic potential to all what you have done. And I think this works wonders if the shape of the head is maintained or there is a mild collapse even. Now here you find, this is 3 years follow-up of a case for the same which I'm showing you. Here also, it's healed. Not healed that I'm saying radiologically. I do some kind of a study. For 3-4 cases I have done. These MRI gadolinium studies have shown that revascularization occurs in the area which we have grafted after debridement. So osteotomy with debridement and grafting is a wonderful procedure because you are offloading the dead bone. So here you find that's the edema and this is the dead bone. Same areas were compared with the gadolinium study, and you find here this green means this is revascularization. This I have seen after 3 years, not after 1 year or 1.5 years. So revascularization, this green means the revascular area, this is the revascularization, is there in this avascular heads. So again, another MRI section, and you see this is after 4.5 years, it is working wonders. The patient who came to me with a stick and a serious limp is quite happy. In all those patients, where I rotated the head by varus or by a valgus or by a flexion osteotomy, but always combined with debridement and bone grafting, it works wonder, even if mild collapses occur later on. Even Japanese have shown the procedure was very well done 40 years ago. Then THR came and intervened. Again, people have started it, particularly me in India. I am doing since long, and it's a long process. It is yet to combine my data. You see here, this is grade 3 subchondral fracture. This is grade 1. This patient came to me from Nepal, and I have done a debridement and a flexion osteotomy. This is the femur, and that is the plate. And this is the angle, about 20-degree flexion osteotomy. I have done it so that the anterior area or the superior area comes more anteriorly, and this becomes offloaded necrotic bone, and a healthy bone comes under the weight-bearing zone. This I did in 19. So you see, this is the flexion osteotomy I have done. That is the weight-bearing zone, and this was the cystic area. And you see offloading the necrotic bone. And here you see this is after in November, and neck looks narrow because it is rotated, and that is the rotation done of the head of the femur, 2 years, and osteotomy healed very well. You see neck is narrowed, and after more time also, I believe there is no limp. He walks very well. He walks very well. There is no limp. He can squat. But I did took precaution that he walks non-weight bearing for some time. This is other follow-up, and that is, I think, 3 years. And these patients continue coming to me, and this is some paper who shows that osteotomy, flexion type of osteotomy, weight bearing osteotomies, they are definitely beneficial and give the more than 78 to 88% of the results as far as 5 follow-up is concerned. You see this girl, that is the lytic area, but this bone is healthy. This bone, she's a dancer, 21. So I have done varus osteotomy on both the sides. After debridement and bone grafting, see here, varus both sides. And the beauty is this, you see here, the bone is forming above the track. Here the bone is forming. I just show you one more X-ray. This slide is, see this track, bone is formed up to the necrotic area which I debrided. It means some kind of vascular activity is also going on. And if you keep these patients for 6 to 8 weeks, non-weight bearing, bone is debrided, dead bone removed, new bone added, that is almost vascular bone, and offload the necrotic bone, it works wonders. In my hands, I am quite happy with this. See, she's doing very well. She herself sent me the video. Anyhow, the gait is beautiful and patient is quite happy. And this is after 3 years follow. You see, this good bone is formed. This one, the beautiful track is formed from the area which was earlier necrotic. So osteotomy is a hope of life for younger age group patients with grade 2 and grade 3 avascular necrosis. And I'm quite happy with excision of the necrotic bone, augmentation with reverse bone grafting, which you take fresh. Another area of disabilities doesn't occur there, iliac crest or the fibula graft, and this seems to enhance the results of osteotomy when you combine it with bone grafting. And we have seen it with MRI gadolinium study that this works wonders. And with this, I thank you very much.
Thank you so much, sir, for a wonderful expression of the way in which the osteotomies and reverse bone grafting do wonders. And definitely, yes, osteotomies. Sir, please stop sharing.
One thing about fibula grafting is just a slide here, you see.
Sir.
Even if you do a vascular fibula graft, if this graft does not go up to subchondral area, it will fail.
True.
This is one example. And I have other patients who were with me, who went to vascular surgeons, my own very good friends. The graft was short of subchondral area, not here. And patient had to undergo THR because this collapsed. So placement of graft, it should be split and it should be drilled so that the creeping substitution is very fast. So that is another important issue when you do fibula grafting.
Very true.
You see, and that's the girl. Crescent sign, you see here. Wonders, you see. I am happy with my follow, you see. Fibula graft was short. There is a collapse. There is a kind of a bone formation or part of the head. I will call it the impingement. Vascular surgeon, many hip surgeons in UK, they tell me, remove this. I said, no. This may also be source of blood supply to the rest of the head of the femur.
Correct.
I will, for the sake of impingement, I will not enter into an event which you are asking me to do it. Please don't advise me. I am happy with my procedure as long as my patient is happy. You see, this patient, now you see, it has undergone further remodeling. See, very simple procedure. People are mad for THR. I think there should be some protocol in this country, at least in the world. What nonsense you are doing. Even in CCOT meetings, I have blasted so many surgeons. The topic is hip preservation, they talk on THR. Very nonsense going on. See, 300 weeks. You see here, this patient can squat. Only thing is he cannot squat cross leg. And he is married. He is an officer in taxation department in Mumbai. So hip preservation, you see, if you have done a technique at the right time, properly, when Thakkar said that stage 1 will proceed to stage 2, stage 2 will proceed to stage 3 or 4. No. Stage 1 can stop and head may become viable. Nature is great. Stage 2 may not proceed to stage 3 at all. So why should we think of THR? I'm not against THR. Do it when it is absolutely indicated. See this wonder. This is 13 years follow-up. This patient is doing very well. I regularly follow these patients. For the people who are mad for THR, I say I'm mad for hip preservation. Well, thank you.
Thank you so much, sir. Thank you so much, sir. Wonderful, enlightening talk. So, sir, please stop sharing your screen. So, yeah, Dr. Karne has a question, but Dr. Karne, can we finish my topic also, and then we can have a good discussion?
Let Karne ask some question, yeah.
Sir, please,
I'm running fever and sitting for you people.
Yeah.
Dr. Not more thing to talk. We will talk after Manish's lecture.
After Manish, you want to make me sit?
Yeah.
Oh, okay. No. Sir, you have done a wonderful. You have a wonderful experience, Magu sir. And what the neoangiogenesis and hip preservation can be done. That can be very well proven. My topic is something related to this, but let me. Okay, I'm not able to share. Just a second, sir. I think. Sir, have you stopped sharing your screen, sir? So
yeah,
stop.
do you need? You asked, okay, I'll share.
Just stop sharing, sir.
I have stopped again, look.
Oh, okay.
I stopped it.
Okay, why can't I go to my presentation? Just a second, sir.
It has come again.
No, you have already stopped sharing. There is some issue at the Dr. Manish's end.
Yeah. Just a second, sir.
How to go out?
No, sir, you are already gone out.
Okay, thank you.
Thank you, Maghu sir. It was a wonderful talk. And may I invite our next speaker, Professor Manish Khanna, who has been pioneering orthobiologics, particularly leading from the front as a founder president of ISCSG, and now in the Rheumatology Society as a president of IORA, to please start his deliberation.
So very true. Thank you so much, sir, for the introduction. So as we have completed 2 hours now, so everything is clear that angiogenesis, new bone formation, new osteogenesis is the back thing, and definitely, as Maghu sir has very well explained, with the reverse bone grafting or with the osteotomy, we can go for it. Core decompression has to be done, and in all the surgical procedures explained by Maghu sir, definitely the core decompression was a part of it, because as you are going to do a reverse bone grafting, that is to be done. So core decompression has to be done once we are across staging 2, 3 onwards. With the insertion of reverse bone grafting technique, with the insertion of the fibular graft, or as we are just going to discuss now, some bone marrow concentrate, some cocktail. But early osteonecrosis is the thing which is to be indicated. Case selection is very important. Why we say cellular therapy? Because in the cellular therapy, it is the bone marrow concentrate which we are using it, the cells, the mononuclear cell cocktail which we are using it, and the early collapse is the sign where it should not be used, because again the dearticulation has been occurred. So pain in the hip with the prolonged standing, sitting after radiating to the ground, they are the condition which encounter us to go to the medical or the surgical management. And definitely, yes, when the crescent sign is there, partial subchondral collapse is there, the choice of the surgery has to be in the most important area. Nowadays, even some PGs, some doctors, they are using PRP, even injecting in the decompression site after the core decompression. The literature, although suggests for the mononuclear cell cocktail or mesenchymal cells to place inside with a scaffold, but yes, PRP sometimes also do well, because again the PRP has an aim of angiogenesis. But what case you are encountering is more important. If you are dealing with a higher grade, when the collapse has not been there, of course, collapse has not been there, the last big area of the lesion is there, then definitely PRP is not the choice. So what is the choice? Is bone marrow harvesting, preparing your bone marrow cocktail, that is autologous mononuclear cell cocktail, sending it for culture, but for the rules and regulation reason, culturing is also not been allowed. But yes, even in our country, there are some places where we can get a cultured osteoblast, which can't discuss right now here in this webinar, for which we'll have another webinar for that. Ultimately, the osteogenesis and the neoangiogenesis has to be done. Effectiveness of the bone marrow mononuclear cells concentrate depend upon the progenitor cells. That means if you are taking a bone marrow cocktail of a bone marrow aspirate of a 70-year-old person, definitely the mononuclear cell cocktail will be less. But fortunately, unfortunately, this disease about young most of the time. So the tissue engineering triad is being followed. That means we use a scaffold. Now that scaffold we use as a G-bone or other modalities, or a scaffold which has already been explained by Maghu sir, that is the reverse bone grafting or a bone stock. What we are adding is as the mononuclear cells or adult mesenchymal cells, which produce the signaling molecules, which are the osteoinductive, basically, which do the osteoinductive stimulus. So whatever the decompression has to be done, you can use it, co-decompression, whatever the way you want it. And luckily, we have seen in our practice that whenever the lesion is an anterior superior side, the prognosis is again not very good. But luckily, when the lesion is in the inferior middle quadrant, the prognosis is very good. So ultimately, also with the regenerative modality, it has been very well explained that the post passing these cells, the mechanical stimulation of the osteogenesis and the angiogenesis can be very well achieved well if the good exercises modality has to be worked up. In these core decompression, followed by bone marrow cocktail, or followed by MSC, or followed by osteoblast culture, or followed by any other modality where angiogenesis to be done in a liquid form, we again propagate of non-weight bearing for 5 to 6 weeks and partial weight bearing after 2 to 3 weeks, sorry. So the full weight bearing is allowed not more than 8 weeks post-operatively. The idea is whatever the osteoblastic activity has been done, whatever the callus has been formed, whatever the healing has been done around that site, it needs time to assimilate. And the radiographic progression has to be done regularly from 6 months, 12 months, better MRIs to be done. We have seen many surgeons across using even a bone marrow cocktail or a PRP or a MSCs or even an osteoblast cultured cells without core decompression, just by placing it intra-articularly. So I have a folded hand on it that we don't believe actually, because the core decompression is the most important thing, which will itself leading into osteogenesis and angiogenesis, but definitely core decompression has to be done. So this is the practice which is to be followed. Quantification of these cells, whatever you are obtaining in your OT from the bone marrow cocktail, ideally the flow cytometric analysis should be done, which should be documented on the discharge slip. So it is not a big deal actually. On all those metro cities where the flow cytometric is being available, you can take out a bone marrow concentrate and you can send it at the same time while you're doing cold decompression, other procedure, you can send it to the lab. Telephonically, you can find it out, and otherwise also to label it off. Well, what are the cells which are doing the job? So the cells which are doing the job are the mononuclear cell. I'm just talking about the bone marrow cocktail, which are the endothelial progenitor cells, because they are rated to be stimulating a wonderful angiogenesis. Although this bone marrow cocktail also has a hematopoietic cells, but practically they don't do anything except releasing the growth factors, because the growth factors are important for the angiogenesis. Mesenchymal stem cells are very less in number in this bone marrow cocktail, so you make it as practically as a 0. So the things work up with the endothelial progenitor cells, with the hematopoietic cells, with the growth factors which do the angiogenesis, at the same time stimulating the endogenous progenitor cells. See, all these avian head, they have endogenous progenitor cells, but they can't do itself unless until we stimulate them up. So stimulating is not possible by any other surgical modality, or stimulating is only possible by, of course, it can be possible to some extent by a core decompression only, because you are again curating the lesion, but mainly it is done by the cocktail cells to stimulate these cells so that they can do their multiplication. Cocktails having greater number of progenitor cells do wonders. They do wonderfully well in the avian hip. So that is the more essence, but we don't have any quantification. We can't, make it right, left, right, that this case would be better. In many of my cases, I've failed with the bone marrow cocktail. In many of the cases, I've done wonders with MSCs, but again, the rules and regulations are there. Now, why I'm saying a bone marrow cocktail? Because this chart will explain you. In normal bone marrow aspirate and a bone marrow cocktail concentrate, they have a total nucleated cell 3.6 times the cell count is there in a bone marrow concentrate, and 4 times it is there in the total mononucleated count measurement which has been done. So such a multiplication of the cell is there with the constant rate. Such amount, doubly 4 times amount has been placed inside as compared to bone marrow. So they do the work. Mesenchymal stem cell, as I've already explained, they are already been there in the endogenous form. But the effectiveness of bone marrow mononuclear cell depend upon the availability of the stem cell having the osteogenic properties. But still, it is a mixed cell population. That's a blessing in a disguise. And definitely, yes, injecting the marrow stromal cells, also secreting angiogenic cytokines, which again do the angiogenesis. So all these things with a graft, after a cold decompression, does wonders. The disadvantage with the culture cell, which is not been used in our country legally actually, is that after the 3 procedure, there are a lot of changes which may happen, and it is a very expensive procedure. Doing culturing a cell, taking 60,000 rupees, 80,000 rupees is again a very difficult situation in our country. Now, when not to attempt any bone marrow cocktail or any MSC or any osteoblast also is definitely yes, as we have discussed this evening, with collapse, never to go for it. And definitely the other regular condition which need not to be read out here, like chronic alcoholic, of the patient is already on the steroid. And just now, a few days back, we received a patient who is having a TTP, that is thrombocytic thrombocytopenic purpura. And we talked to the hematologist. They say we can't stop the treatment. So we can't go for it for the stem cells also in that way. So to determine the most appropriate treatment, we have to consider the age. And luckily, these patients are young age, stage of the disease, location, amount of the bone is affected, and the underlying cause. Hyperuricemia has many times been associated and as many times been explained by the Mukherjee regime, Dr. Mukherjee also, arthritis is one of the cause which needed to be labeled, but it is a different altogether story. We can't take it all over here. So what result we are going to expect? So this was a hip. I'm just placing one example here. Definitely such hip require arthroplasty. Now, in this case, I want to make a feature here, like after 1 year of the BMAC, this was the result which I achieved. And in fact, in all the cases, I've seen a little bit of head has been enlarged, and that has already been published. These publications already been there. Lot of sclerosis has been there, but as Dr. Magus has very well explained it, increasing sclerosis, increasing a little bit of head size, apparently here, does not make a difference unless and until we are not going to reduce, we are not going to see any reduced joint line. So maintaining the joint space after 1 year of a surgical intervention, maybe it's a core decompression along with the grafting, whatever it may be, maybe with the osteotomy, maybe with the BMAC, maybe with the MSCs, and having a good, we can see here I'll go for the next slide. You can see here the amount of the new bone formation, which is condensed. Definitely it require a period of 6 months or so for allowing the weight bearing. Sometimes I allow my patient weight bearing to be more delayed, which is again a challenge. But again, it should be at that stage when that new bone which has been formed is not in a sclerotic form. It is already in a condensed form, truly speaking. So my take-home message would be in the early stage of AVN, the regenerative modality dramatically decreases the pain, of course, and pain is being decreased as we have discussed even by core decompression or by other modalities or the drugs. But retarding the progression of the disease, if we can make by rebounding osteogenesis, then I think the job is being done. Thank you so much. Now we can, I'll stop my sharing and we can have a panel discussion. Yeah, over to our chairs. Dr. Raghunandhan, Dr.
Srivastava. Can I have a few minutes because I have urgent work I have to leave. So if Dr. Manish can allow me to speak a few minutes.
Please,
okay?
please.
Yeah.
Please, definitely.
Just because,
yeah, please. Yeah.
And all the presenters have beautifully made their experience, which is really exemplary, and which has given enough information about how to go about for different modalities of treatment and different stages of AVN and osteonecrosis of the hip. So a few points. I think it is better to add arthroscopy in each and every osteonecrosis, particularly if you're going to manage surgically, okay, apart from conservative treatment, because 80% to 90% of the times there is associated intra-articular pathology when there is osteonecrosis of the femur. So if you're trained to be an arthroscopic surgeon, it is always wise to put arthroscopy. And if it is a treatable condition is there, you can always treat the intra-articular problem as well, so that you can prolong the outcome in a better way. And number two, in case of AVN or osteonecrosis involving the lateral part, which is the weight-bearing portion, which is very critical, and we know that the prognosis is poor. And if the lesion is very large, where a single tract of decompression and reverse bone grafting, sometimes difficult to cover the whole arc of necrosis. Sometimes the trapdoor technique, which is very helpful, where you can directly reach the necrotic portion, remove all the necrotic portion, and then pack it with the bone graft nicely to support the subchondral bone so that it doesn't collapse. And then you can add, of course, orthobiologicals at the same time. And number three, as Dr. Magoo has clearly told us that, please do not worry about if the healing process is not going in the right direction, even if some collapse is going to happen, because most of the patients, they do very well, even at stage 3C or early stage 4, because most of the times, only the femoral head shape changes, but the acetabular side, still the arthritic process doesn't catch up as soon as how the femoral head shows. So the most of the patient, they do very well, even in long term. So don't worry about that. Don't rush for total hip replacement unless the patient really demands for his pain. These are the few points I would like to add. Thank you.
Thank you so much. Thank you so much for the input. Yes, Dr. Karne, sir. Over to Dr. Sandeep, sir, for the...
Minister, thank you so much. It had been a wonderful session, right from medical management to surgical management early. I think head preservation is here to stay, though there is still not a perfect answer right now, but logical solutions built on each other is the way out. And as rightly been put out, a little bit of medical management initial stages, and then the surgical management to stop the disease, and then particularly orthobiologics to reverse the disease may be the answer for the future management of all this huge problem which is there. And very well has been explained by Dr. Raghunandhan as well, that we need to keep our eyes and mind open to accept modalities such as arthroscopy to assist further regeneration and arrest the degeneration faster. It does not happen very fast. So thank you so much, all the speakers, for this session.
Well, thank you. Can I speak now, sir?
Yeah, Dr. Karnes,
yeah,
please.
Now we'll go one by one. Just we'll go from the last two first. Dr. Raghunandhan has said that arthroscopy is useful. At what stage you think that arthroscopy is useful? Because as long as the disease is intraosseous, it has not gone out up to the stage 3, then mild collapse is there. So at which stage? In stage 2, is it helpful? At stage 3A also, what kind of the intra-articular changes? You said a lot of changes are there. Because what kind of changes you have found in the intra-articular area in the stage 2 or stage 3A? Because stage 3B is like any arthritic hip. But what you have found there and how it is useful to the patients in that part?
So stage 2, if you're planning to do a core decompression, it's always wise to put, or better to put the scope inside the joint. Because most of the times in the stage 2, which is a very early stage, it's a transition from 1 to 3A, the stage 2. But there are changes are not so great as like in stage 3A, okay? But if you see a treatable condition, like some minor labral tear, or sometimes you can see some cartilage defect, you can address at the same time, number one. Number two, you can sometimes, in the X-ray, you may not able to see, the Shyam images, you may not able to see the necrotic portions clearly. So because you can see clearly in the MRI scan, but in the Shyam screening, you don't know where the location of the necrotic bone. So the arthroscopy helps in a little bit, when you feel the cartilage over the necrotic bone, it is softer than the cartilage which is over the healthy bone. In that way, you can use that pointer as a guide for you to reach the target in an accurate way. So these are the two benefits which I see in stage 2 or early stages. So in the stage 3A, when there's a crescent bone, but you still want to salvage the hip, there are more common associated problems like cartilage delamination we have seen, and as well as the labral pathologies, which is very common. So if we can treat at the same time, then very well and good, so that you can prolong the life of the your outcome.
So this labral pathology has nothing to do with the osteonecrosis, right?
I don't know whether there's a positive correlation between the osteonecrosis and these kind of problems, because even some authors have described cam lesion is also very common in this kind of avian. So like if the patient has got some abduction limitation, you can do a cam plasty at the same time so that you can improve the outcome. So in a better way. And also sometimes I add a tunnel endoscopy as well when I do the decompression. So where you can put the scopy inside the tracts to see the femoral head, how far you have removed the necrotic bone. So if you can rotate the scope and see all around 360 degrees, if you see still some amount of white necrotic bone is there, you can take it out and then put your curette and gently curette it out, all the dead bone. And again, put the scope and confirm you see the bleeding margins. Then you're very sure that you removed all the necrotic bone, and then you can do the bone grafting as well.
Want to add one thing on this, Dr. Raghunandhan, that is very importantly, as you have mentioned, that scope is important. Truly speaking, yes. And in fact, what I say is doing a scopy prior to the surgery many times, because what I want to emphasize is here, when you see a lesion in an early stage in the chondral, the cartilage lesion, if you place a BMAC or a bone marrow cocktail, it wanders also. But doing a scopy and putting a cocktail will again lose your thing. So maybe if you can see a lesion and later on at a later date, we can go intra-articular injection. It works very well most of the time.
Okay. Now we'll go from the top down. When the core decompression, we are just drilling. What I do is I remove all the necrotic bone, because there is no point in keeping the necrotic bone there at the place, and so that the substitution or the creeping, I won't say creeping substitution, the formation of the cancellous bone will be there better. Because what we see in the proximal tibia as well as the calcaneal fractures, in the past we were using the bone grafting for the depressed bone, because the cavity which is there in the cancellous bone has to be filled with some cancellous bone. But now it is proved that even if you keep it there, the cancellous bone cavity fills up. So removal of the all necrotic bone will help the nature to concentrate on the healing or the osteogenesis rather than cleaning up that particular part. So that is the one variation I do for last 2 years. I remove all the dead bone and I use the same 10 mm cannulated reamer of the ACL and just do the circumduction movement and take all the bones. Here I have found those patients who have taken bisphosphonate before therapy, the bone is become more sclerotic, and one of the speakers said that becomes very difficult. The simple drill sometimes cannot go there. But then if you use the ACL reamers, you can remove completely, because the opening part on the lateral part is much smaller, but you can use a wider bone. If you're using simple ACL, there is no need. There are certain expensive gadget by certain companies where you can use that remove all the necrotic bone, but simple ACL 10 mm reamer is helpful there. Another part, when we go from lateral window is hardly 1 square centimeter, and when you want to reach this sclerotic bone, as Dr. Magu is doing, I take all that bone cylinder, or you can say the whole cylinder from the lateral cortex up to the necrotic bone, and I use there in that particular cavity. I pack it up there. I just don't put that simple this, because the cavity is very big and your cylinder is narrow. We can say hardly 10 mm diameter cylinder. So I put that whole bone. So there, the natural bone graft, it will help for the support also. And in addition to that, I put what Dr. Manish Khanna has said. From 2012, I'm using the BMAC. The BMAC is one which is very easily available and extremely useful for additional, rather than just a bone plug there. Additional angiogenesis as well as osteogenesis is very much helpful with that particular BMAC. So combination of the removal of the whole of the not core decompression, whole of the necrotic bone, you can feel there is no need even a simple feeling. No need to go for arthroscopy. Even the CM also, you can just feel that there is a soft bone. When the soft bone comes, you stop there and remove all the hard bone by doing the circumduction movement. After that, put the bone plug. After that, put the BMAC and put that window. We close the window of the lateral window because I remove a square window out of that. So all these things help the patient, and there is a combination of multiple things here you can say. Now, about non-weight bearing. When you are doing the non-weighting for 6 to 8 weeks, patient has to avoid the straight leg raising also. SLR, because SLR puts a lot of weight. Rather, the weight is sometimes more than the weight bearing weight on the load across the joint. So it's one of the important points which the patient had to be told to avoid the SLR completely. Then about another part, the fibular bone graft I was doing for 25 years. The fibular bone graft or any metal which is given for the support of the subchondral bone. Now, after the era of the orthobiologics, this was all before the era of the orthobiologics, the fibular bone graft and everything else. Now, after the era of the orthobiologics, it has been proved that these orthobiologics are far, far more superior than the fibular graft. As Dr. Magu showed just now, the fibular graft was not helping at all for the vascularization. It was supposed to give the support to the subchondral bone there. And if the subchondral bone support is not there, the fibular graft, it fails. Rather, it is the cortical bone graft, and how the cortical bone graft is going to provide the vascularization, it's just a matter of the logic. So that is as far as the fibular bone graft and the, you can say, the is concerned. Third part is about osteotomies. Osteotomies will be helpful only when there is a deformed femoral head. That is, you can say after 3B or 3C. So you can combine that in that condition, 3B and 3C, you can combine the osteotomies to deload the necrotic area and put the load on the normal area. And there you can again combine all those things, we can say the muscle, right from core decompression to the paralysis and everything. And as I said, we can have excellent results with the osteotomies, but osteotomies are not, why osteotomies has to be done in the stage 1, after stage 2 or the stage 3A. So when already collapse is there, you can use that part. The paper which sir has shown in 1993 paper, which is before orthobiologics. Now, one of the part which I want to ask about the MRI, the radiologist, that is there any postoperative analysis of the MRI, how the MRI can help in the progression or the result and the postoperative manner, because we have removed everything, but we don't know when the collapse is going to occur. We don't know when the process has stopped, and we don't know when there is complete substitution. So I wanted to know from him also how MRI will be useful in the postoperative cases to assess the progression of the healing. The third part was that, as sir said, that BMAC is definitely useful, better than the PRP, because PRP has got much less osteogenic potential, the osteogenic potential, and BMAC is immediately available, same like PRP. So when the you can have the Mercedes car while you are going for the small Maruti car. So there is no point in using BMAC, PRP. BMAC is useful. Stem cell, what happens? Stem cell has got definitely more osteogenic cells as compared to BMAC, but there are no growth factors into the stem cell, because most of the institutions they are recommending stem cells, which is far more expensive than the BMAC. BMAC is available hardly for 20,000 rupees for both the hips, and this stem cell goes to more than 3 lakhs rupees. So one part is that it is immediately available in the operation theater, and second part is the bone factors are far more than the PRP. Third, more important part is that you have to wait for about 4 to 6 weeks to get the stem cell cultured. And in that particular period, because the key point is the collapse, and I have seen the collapse has occurred within 3 weeks of the delay of the management. Patient goes around for the shopping, he comes back to 3 weeks, and there is a collapse. Because once collapse develops, because first aim should be you have to restore the normal head. After that, once collapse occurs, what we have to think that we are buying time for the THR. You have to increase the life of the natural head, but at some or other point you have to replace that. So PRP, BMAC is far more superior, that it is immediately available as compared to the these cultured stem cells. And other part is exercises. In post-op management also, the treatment doesn't stop at the surgery itself. After surgery is done, then why not go for all the medical management like the teriparatide or the Mukherjee's regimen, all those things? I go for the post-op period, because they themselves claim that the patient is very much, as Dr. Magu said, that patient is very much happy in spite of such a distorted hip. The patient is very much happy even when the X-ray changes are bad. So why not combine that in the post-op period? We have to combine everything. And in addition to that, as one person has said about the exercises are really very, very important. So proper exercises, that also range of movement exercises, not load bearing load or increasing load exercises. The range of movement exercises are very much helpful. So combination of the core decompression, bone graft, that is that cylinder graft, BMAC, and followed by the proper all the drug regimen along with the teriparatide and the exercises has to be the whole pattern. That is what is my protocol for last about 6-7 years. Now, I'm doing BMAC for 12 years, but the all protocol has helped a lot even in 3A and 3B patients. That is a comment.
Yeah, very true. Thank you so much. Plus the size of the lesion. If it is the entire head is being involved, strategy has to be different. And if the lesion is little smaller in the superior aspect or inferior aspect, then the strategy will be different. Thank you so much.
That's a very nice discussion by Dr. Karne. But in spite, see, we have been doing BMAC. I definitely understood the bone marrow concentrate. We have been doing for so many years, past 30 years of the practice. But as the science advances, we should not even, sometimes, yes, we should think that the cultured osteoblasts are also having really a good role. I understand, except for the expense part of it.
Yes, it has extra.
It is the expense.
Yeah,
but
it is a little extra money, but the selection of the case is very important, and the cultured osteoblast also has an important role in treating AVN, but the selection of the case is very important. Rest of the other things I agree.
We are not discussing culture osteoblast because if you go for the rules and regulation, it is FDA approved to some extent, but cost 1.5 lakhs of rupees.
I agree. I'm not saying other than the cost.
This is for the
other than the
masters.
cost, yes, definitely. Yeah.
But we will definitely discuss. We will definitely discuss this thing also sometime else.
One more point I want to make, sir. One I forgot that one of the slide was shown that intra-articular installation of the BMAC or JRP. This intra-articular is the disease, whole disease, is intra-osseous disease. How the extra-osseous. So how the extra-osseous things are going to help for the disease which is intra-osseous.
Nothing. Only in that case, as mentioned by Dr.
It may take care of early osteoarthritis with that intention.
We are finding out any lesion which is been there, which we want to regenerate the cartilage. Only in that case. Otherwise, not. No use. But people are claiming, so that is every type of different type of
word. Claiming everything for best result for everything. So that is the scenario right now. Nobody has said that this particular procedure is not effective. Right from the intraosseous bisphosphonate, there also paper intraosseous bisphosphonate helps a lot. Everywhere all papers are there.
Karnesa, it is a very controversial topic with a lot of good work being done and claimed by the physician and surgeons and everybody. Only with the discussion on, we can reach to some consensus. Otherwise, it's very difficult, actually.
Absolutely.
Yeah, thank you so much. Thank you so much. Excellent. I think we are already almost going to be 3 hours now. And I will request our convener, Professor Bhusan, sir. Are you here, sir, for the final? Dr. D.P. Bhusan, sir? Oh, he has left. He was here. For the Dr. Bhusan, sir, are you here?
Yes, I'm here.
So let us wind it off and we'll go for the next series next time. So a take-home message from your side, sir. It's almost 3 hours now.
That is very important. I was in a conference, Ram Chadda. I would like to introduce you. Ram, come here. I'll take 1 minute of yours. Come.
You will get
so meanwhile,
the length of the screw required. The length of the screw, you can
you see?
Yeah, we can see.
President-elect.
You don't want the threads. You want the threads.
I think you are busy in the conference, so there's a lot of noises.
So we are finally giving you the message.
Yeah, fine, sir. Please. So
our best wishes for the next conference and the next webinar.
Sure, right? Sir. Sure, sir. Dr. Ram Chadda wants to say something. Yeah, thank you so much. So, before winding it off, any comments from any respected stalwart here, the chairs, the speakers, anything which we want to convey, anything which is your mind regarding, because we have covered, a lot of things altogether. Yeah, thank you so much.
Very well done.
Thank you.
Okay, it had been a wonderful session.
Thank you.
And I think so we should look at the road ahead. And if we can come out with certain guidelines that out of this discussion, it would be wonderful for youngsters.
Definitely. Professor Anup want to say something? Professor Anup?
I just about the biopsy part, while doing or studying the cause of this AVN, when we are doing this biopsy, will it be a CT guided, Shyam guided, or how do we go ahead with it?
So definitely, sir. I think when we are planning for a biopsy, what the result was being told by the speaker was combining all together. When we are removing the necrotic bone, that is a one way for going for a biopsy. Otherwise, it will be.
If we are doing a procedure, then it is fine. But we have opened it and
no, sir. That is the best option. That is the best option. Otherwise, two surgical interventions will be.
I just want to know, while doing operation, if you are doing biopsy, how is it going to alter our post-op management, either in medical form or in...
I'll take this question. So like Manisha, if it is you are only doing planning for a minimal invasive type of things like core decompression or something like that, then definitely the biopsy and the procedure goes hand in hand.
Yeah.
But if you're planning for THR, it is better to do a small biopsy before as a core. It helps because at times we have found, Dr. Saudi is not here, that
Yes,
they
sir, I'm
reported.
here. I'm here.
Yeah, so sir, you
Yeah,
can tell
that's
this, that in 20% of cases, even there was a diagnosis of tuberculosis which came out instead of AVN, which was reported on very high intense T1 and T2 images on MRI. Can you explain on that, sir? So it does exclude certain
So
things
diagnosis,
which are more important.
sometimes there is a misdiagnosis, and even tuberculosis was there. So if you are doing a biopsy, you must send it for histopathology. Histopathology
yeah, that
is
is for the open.
Open. When you do a decompression, you send it for histopathology. Even if you do THR, you should send it for histopathology for further study, for our knowledge.
True.
Yeah.
Maybe sometime if
we
you
are
come
going
across
for
some
a close,
infection,
the
some
decompression,
tuberculosis.
that time we are sending all the samples.
Sometimes always you must send, because you may get surprise results from the histopathology.
Absolutely. Even if it's 1% incidence, then it's better to go for that particular to rule out additional tuberculosis or any other. There is one of the person who is in our group who is saying that he aspirates and the chance of the fungal infection are more. Yes,
I too agree.
Yeah.
So that is why, because fungal infection, I know I don't wanted to take this, but definitely I will invite all the stalwarts who are feeling like that these are the causes with the proper literature, so that we can add on all these things to know about. Maybe we are missing out something in that direction also.
That's it. Yes.
True. So finally, thank you so much, everyone, for the kind time.
On behalf of all the faculties and all the delegates, I profusely thank Professor Manish Khanna, who has taken such a tremendous efforts. And, he was so perseverant and so much these things that because of him, we can have so much time, and it was such a lovely discussion. So we wish that such webinars come again and again at different parts also, where we can have a full discussion of a whole day. And I really thank you for bringing this topic and combination of the old styles as well as new orthobiologics. Everything has been covered. Thank you very much.
Thank you so much, sir. Thank you, everyone. Thank you.
Thank you, sir.
Thank you, everyone. It has been a wonderful session. Thank you, Manisha.
Thank you, everyone.
Thank you. We're signing out now.
Poonam, you can discontinue, Poonam.